Good afternoon. Welcome everyone to the Senate Committee on Health and Human Services. Madam Secretary, please proceed to call the roll.
Senator Lang?
Here.
Senator Nguyen? Senator Titus?
Here.
Senator Stone? Chair Donate.
And I'm here. Please mark Senator Stone and Senator Nguyen as present when they arrive. They're in a different committee meeting right now. Good afternoon. Everyone's present. Madam Secretary, please indicate that all members will eventually be present with the other two. Today we have a bill presentation by the Nevada Hospital Association and the bill hearing on Senate Bill 419. So just as for folks who are interested on the agenda item, this is the way that we'll do today's agenda. So we'll start off by welcoming the folks from the Nevada Hospital Association to present on uncompensated care. After that, we will move to the next agenda item, which is Senate Bill 419, and then we will proceed with testimony, etc., throughout this process. We have reached capacity here in this room, and there is an overflow room as well. So as folks are watching the bill presentation, just pay attention to the remarks that Vice Chair Nguyen will give you as to when it's appropriate for folks that are in the overflow room to come into this room, and we'll try to encompass everyone for the sake of this presentation. A few housekeeping items that we have specifically for today. First, I am very excited to announce that we do have a Spanish translator available via Zoom for today's presentation. We will make sure that if this applies to you, we'll give you notice as to when you should come forward. We ask that if you do require Spanish translation, that you speak in segments so that the translator is able to adjust and translate accordingly. Para los que quieren hablar en español, hoy sí tenemos el servicio para traducir el testimonio que vamos a tener para el proyecto de ley. Si necesitan ayuda traduciendo, la única cosa que los vamos a preguntar es si pueden hablar en pocas palabras para que puedan ayudarles durante el proyecto de ley. Furthermore, we ask that public comments be kept to 2 minutes so that everyone interested in speaking can be accommodated and ensure that we can get through the agenda in a timely fashion. And speakers are urged to avoid repetition of comments made by previous speakers. If you've run into the instance where you aren't able to express yourself in those 2 minutes, of course, you can always submit your public comments to our committee staff, who are graciously staffing us here today. If you wish to testify, you can please sign in at the table by the door and provide a business card to the committee secretary if you have one. If you do not wish to testify, you can also sign in as well. And just know that the chair or a member of the committee may request testifiers to submit documentation to support their testimony today. When testifying, please turn on the microphones on to speak and off to listen. We have listeners and viewers in Las Vegas and online and recording this meeting, as it will be available on the legislature's website later. And a reminder to all those who testify, pursuant to NRS 218E, it is unlawful for a person to knowingly misrepresent facts when testifying before a legislative committee. A person who knowingly does so is guilty of a misdemeanor. Anyone who wishes to receive copies of the committee's exhibits should go to the legislature's website. And finally, we ask that everyone please turn off your electronic devices, especially cell phones and laptops, or put them on silent mode throughout the meeting. So as we await our committee members to come from their other committee, we're going to go ahead and proceed with the presentation from the Nevada Hospital Association. I'm very honored to introduce with us Mr. Pat Kelly, who is the president and CEO of the Nevada Hospital Association. We have a very important discussion today on uncompensated care, so please begin when you're ready.
Mr. Chairman, members of the committee, thank you so much for inviting me back to speak. As you recall, I was here a couple weeks ago talking about the status of hospitals in Nevada, and in that presentation I had a slide or two on uncompensated care, and the chairman asked me if I could elaborate on that a little bit. So that's my plan for today. Sorry, the slides are not advancing. In Nevada, we have about $1.26 billion in under-reimbursed care each year in our hospitals. And as you recall, the last time I presented about 19 hospitals. And the reason is that under state law, the largest hospitals in the state are required to file information annually, and there's a hospital annual report, and that's where I'm deriving this information. So we're not counting all the hospitals today. We're going to be primarily looking at the 19 largest. So, I've got this time, I think. I'm just going to use this. Thank you. So who are these individuals who are part of the uncompensated care? We have Medicare patients, Medicaid patients, underinsured patients, uninsured patients, and undocumented patients. So this group represents about 75% of the care that's provided in these 19 acute care hospitals. So it's a significant amount. And what you're going to see in the video I'm going to show you is that each member of that group doesn't pay the full cost of the care that they receive. So, you know, there's a difference between cost and charges. I'm not talking about charges. I'm talking about the base cost. So
If you have private insurance, you're probably wondering why your health insurance is expensive. One big reason is cost shifting. You pay the cost of your care plus part of the cost of care covered by government programs. Let's say a procedure costs a hospital $1,000 to provide. Nevada Medicaid will pay, on average, $530 for the procedure, or about 53% of the cost. Some hospitals receive a supplemental payment from the government, but not all. Now, let's look at Medicare. Nationally, Medicare pays, on average, $870, or about 87% of the cost. Now you may be wondering, if both groups pay less than the hospital's cost to provide the service, who makes up the difference? The answer? Union members, small businesses, families, and anyone with private insurance. These groups pay more than the cost of their care. The cost is shifted from government programs to patients with private insurance. How big is this cost shift? It's huge. Approximately 70% of the care provided by Nevada hospitals is to Medicaid and Medicare beneficiaries. Additionally, the cost of care provided to people who are unable to pay their medical bills is also shifted. In all, nearly 75% of care is partially subsidized by the insured groups. That's a lot of shifting. Small businesses and families can't continue to pick up the cost of these government programs. They're already paying too much. Government programs should pay at least the cost of the care provided. If you have private insurance, you're probably
So if you're interested in seeing that video, again, it is available on YouTube under the Nevada Hospital Association's channel, and it's also available in Spanish. So we have both options available. So let's start taking a look at the different groups. We're going to start with Medicare, and about 17% of Nevadans are Medicare beneficiaries, and they're the largest utilizers of hospital services in the state. They represent about 40% of the patients, and it makes sense that they would be the largest utilizers as they are older individuals who typically have a lot of health issues. Now, the thing in this presentation, Medicare is a program that's a federal program, so the state doesn't have a lot of influence on it. But I wanted to share with you just that Medicare is a cost shifter because they have to be considered in all this. But this is an area that the Nevada Legislature does not have much influence over. So let's take a look at the areas where the legislature can have some influence. And we have about $1.1 billion in under-reimbursed care that's offered each year, and that goes to these four groups: Medicaid, underinsured, and uninsured, and undocumented individuals. And we'll take a look at each one of them. So with Medicaid, we have about 1 in 3 Nevadans who are Medicaid beneficiaries. Now that number is probably going to change a little bit in the near future, because at the end of the public health emergency, there's going to be a reevaluation of whether people are still eligible to apply for and be serviced by Medicaid. So what will happen, we hope, is that a lot of the people who during the pandemic lost their jobs and went on Medicaid will have found jobs by this point in time and will have some private health insurance. But if not, they'll have to look at, they may be able to re-enroll in Medicaid, or they will be eligible for the Silver State Health Insurance Exchange and get their payments there. But as we said in the video, Medicaid represents a huge cost shift. It's 51 to 53% of the cost that's covered, but the rest is not, and that is shifted on to other groups, commercial insurance primarily. Now this chart's an interesting one because it looks at the growth of Medicaid rates and the growth of hospital costs. So the bottom line is the Medicaid rates. As you can see, it's not going up dramatically from the 90s. And then you look at hospital costs, and they have gone up dramatically. And the gap is about 50%. And if you look at the bottom line on the Medicaid rates, you'll notice that there's really only in the last 20 years about a 5% increase in Medicaid rates paid to hospitals. And I'm not talking about 5% each year. This is 5% over 20 years. This graph looks at the contributions made by 3 different entities towards hospital Medicaid costs. So the state contributes about 14%. That's matched by the federal government at 37%, but hospitals come up with 49% of the contribution. So they're much larger than any of the groups. There's a category that's kind of interesting. It's called dual eligibles, and these are people who are eligible for both Medicare and Medicaid. And we have about 78,000 Nevadans who fall into this category. And Medicare is the primary payer on this insurance, and Medicaid comes in with the co-pays and the deductibles. But when it comes to hospital care, Medicaid does not pay the co-pays and the deductibles. That's a cost that's absorbed by the hospitals. We have to look at insurance plans because they're starting to have an impact as well. So when we have high deductible plans, we have people who are getting plans that they probably really cannot afford, and they're hoping that they're not going to get sick. The IRS defines a high deductible plan as $1,400 for an individual and $2,800 for a family. It's not unusual to see $5,000 deductibles under these plans for a family. And for a working family, that's a substantial burden. They don't have $5,000 sitting around if they have a medical emergency. We now have about 45% of Nevada's workers enrolled in these high deductible plans. So what happens is when they can't pay the $5,000, that's another cost that the hospitals absorb. And because these plans are becoming so popular, we're seeing a lot more expense in that category. Another health plan that's of concern are the high share plans. This is where an insurance company will pay 80% or 70% of a hospital bill, but the policyholder is required to come up with 20 or 30%. And that's a huge amount of money for a lot of working families. And so because they can't pay that, that's another cost that the hospital absorbs. The uninsured, we have about 13% of Nevadans who are uninsured. There was an interesting study when they were working on the public option. A company called Manat was hired to come in and do a report. And one of the things they found that 83% of the uninsured Nevadans were either eligible for Medicaid or for the Silver State Health Insurance Exchange, but they weren't taking advantage of either one. And I think this is probably one of the most ripe opportunities to go out and try to work to get these individuals insured. Every hospital has a charity care policy, and they usually are based on the federal poverty level, and then there's typically a discount policy that goes with it. So it's kind of a 2-component. If you meet the federal poverty level requirements, then the care can be free in certain circumstances, and then if you don't, then there's a discount policy that applies as well. I believe there's a state law too that if you're self-pay at a hospital, you get a 30% discount on that. Undocumented individuals, this is an area where we don't have statistics on it because we do not track whether a person is undocumented or not at the hospital. There is a part of Medicaid that will provide for Medicaid emergency services, but it's limited to acute emergency medical conditions, labor and delivery, and outpatient dialysis services. So it's very limited in terms of what it covers, and it only covers until the person is stabilized, and then there's no fund to be able to take care of them after that. This chart kind of shows the trends of where things are headed. So if you look at the left, and you can just see it went down slightly in the middle, and then starting in 2019, it starts to go up. So you see the rate of uncompensated care for Medicaid increasing, while the uninsured, which is the blue at the top, is slightly decreasing. But you can see there's a definite trend line with respect to Medicaid. Now, one of the things the chairman asked me, he said, well, if we could help and eliminate some of this uncompensated care, what would be the benefits of closing the gap? Well, the first one would be that individuals who are on commercial insurance would not have to be subsidizing as much of the care provided to the groups we just discussed. I also believe that over time that people would start getting better care and having access to care so that when we see them in the emergency room, they're not in a terrible situation. We hope that we could avoid that and not have those types of admissions coming in. So I think there are a lot of different things that would help as we fill the uncompensated care gap. So that's my presentation. I'll be happy to answer any questions that you have, and thank you again for the opportunity.
Thank you so much, Mr. Kelly. I think for the committee members, this is an important conversation. I think the rising levels of uncompensated care is something that we have to address because they're continuously increasing. I think there's a question that I'm going to ask you that perhaps is the sentiment that we hear, which is, you know, how does this play out in terms of like the actual spending of care that is delivered? Can you explain to the committee members and of course to the general public that's watching today, is there a law that requires hospitals to take care of everyone when they step into the emergency room? Like why? I guess, you know, the reality is we do have to pay for it in some way, shape, or form. So is there a law that was passed?
Yes,
and long ago, and maybe if you can clarify that.
Yes, Mr. Chairman, there is a federal law. It's in EMTALA. When anybody presents at an emergency room, they will receive care until they are stabilized. And that is a strictly enforced law, and all the hospitals follow that very closely. It's the Emergency Medical Treatment and Labor and Delivery Act or something along those lines. That's what EMTALA basically stands for.
Thank you so much, Mr. Kelly. So what I'm hearing is we're paying for it regardless. The question just comes to who's the burden shifted on, and for the most part, it's for the hospitals and the clinical providers.
The hospitals have to absorb it, and they hope that they can shift that cost to the commercial payers, but they negotiate with the commercial payers, so you just can't automatically shift everything to them.
Thank you so much. Any questions from committee members? Vice Chair Nguyen.
Thank you, and thank you for that presentation. I think we all know that uncompensated care is a huge problem. And I may have missed it. I apologize. I was still sitting in Senate Judiciary at the time you began your presentation. But what does that dollar amount look like of uncompensated care within the Nevada hospitals?
For the 19 acute care hospitals that we have the data reporting, it's about $1.3 billion. And that includes Medicare too. If you don't include Medicare, it's about 1.1 billion.
And then can I ask you another question? Currently, obviously we're talking about private hospitals. So are the private hospitals, how are they handling that uncompensated care? Are they just, are they writing off as like tax losses? How is that working currently?
This includes the public hospitals too. Those 19 include some of the public hospitals, so it's a mixture. Basically, unfortunately, we have some hospitals that have some significant losses. We have over half the hospitals in the the state, who in the first 3 quarters of last year had negative operating margins. So they're not being able to shift all the money they need to be shifting. We've had hospitals that have $100 million losses in the last annual reporting for them. So, I mean, there's significant issues, but yes, do they try to recoup the costs in other areas? Absolutely. And if they would have a loss and they were a for-profit, then they would probably be able to get a little bit of a tax write-off, but that's certainly not the goal.
Any other questions? Mr. Kelly, the question that I wanted to ask, so, you know, Vice Chair Nguyen mentioned of how uncompensated care actually plays down, which is someone has to pay for it at some point, because historically, longer than any of us federally, we have designated that hospitals have to take care of anyone that steps into the emergency room. So I guess my question is not really on uncompensated care, but rather so the circumstances that your hospitals are encountering in the emergency rooms. Are there situations because of uncompensated care where people aren't able to access, say, health insurance coverage, where they're turning up to the hospitals with more catastrophic outcomes? Does that lead to your ERs being more crowded? Like, what's the general outcome of what you're seeing right now on the ground?
Well, I think what we're seeing is that people who don't have access to primary care services often get sicker and then present themselves at the emergency room. So we're taking care of a sicker group. We also have the issue where, because we don't have enough access to primary care, that people are coming to the emergency rooms for primary care. It's about the most expensive place you could get your primary care. But you know, as I said, we take care of everybody and see everybody who comes through and try to help them and get them on their way. But yeah, I mean, we need access in the state in so many different areas, and primary care is one. And even once you identify a problem, we need better access to specialty services.
Thank you so much. And then last question, just for clarification, 1.2 billion, that's annually? Or can you reference the numbers one more time, please?
Yeah, let me just go back to the slide. I want to make sure I got it right. It's 1.26 billion annually.
Thank you so much. Last go around, Senator Stone.
How are you, Mr. Kelly?
Very well. How are you, sir?
Sorry, I wasn't here for most of your presentation. Thank you for the notes. I look forward to going over them tonight. 1.26 billion, I think you said. Now that's for people that present at the emergency room with urgent situations that need to be stabilized. So if the law were changed that anybody can go to any doctor or any hospital for any condition that doesn't have insurance today, what kind of a multiplier effect would you see that 1.2 billion? Would you see it maybe 4 or 5 times as much if people could come to you for a hangnail in the emergency room?
Well, Senator, that's a great question. I really don't know, because it would be a huge multiplier effect.
Yeah.
I'd be worried if I said 4 or 5 that'd be too small a number, because if everybody starts using emergency rooms as primary care centers, oh gosh, it would just go crazy. We couldn't handle the capacity with the current infrastructure.
You couldn't handle it. How about the Medicaid system? So, you know, let's say we did have a sudden influx of 500,000 people. Let's say they all had to go into Medicaid. How would we accommodate the existing Medicaid population? Would you see a dilution of services because there's only so many providers that can see these people, and there's only a finite amount of money that the state puts up that gets a federal match? The state would obviously have to put up a significant amount of money to accommodate this growth in the Medicaid population. And get the federal match, which is very important, wouldn't you say?
The federal match is extremely important,
Yeah.
the whole thing. Yeah, the state would have to come up with more money to be able to expand the programs. And frankly, right now, we need better access to care for people who are on Medicaid and a lot of other programs.
So at a 5-time multiplier for any kind of health care needs that somebody would need, the state would be looking at least $5 or $6 billion more in expenditures to accommodate the uninsured population.
It would be a significant amount more.
Thank you very much.
We have a question from Senator Lane.
Thank you. I think you said, and correct me if I'm wrong, that 83% of uninsured are eligible for insurance, but they don't take advantage of getting it.
That report said that 83% of the uninsured are either eligible for Medicaid or for subsidies on the Silver State Health Insurance Exchange.
Right. That's what I heard. And so, is there something because you get these patients into the hospital all the time, is there a program you have in your hospital to try and get them insured?
Yes, yes.
And what would that be?
A representative will come down and try to work with them to find the payer source. First they'd identify, do you have commercial insurance? When that doesn't happen and they find out that there is no insurance, they would start inquiring as to whether you would qualify for Medicaid. State Health Insurance Exchange, we can't do, right on the spot, but we can direct them to that area. But they can get become eligible for Medicaid, start the process at the hospital.
And have you had success with that program?
Oh, absolutely.
Okay, so it would be way more if you didn't have that program.
Yes. Yeah.
Okay.
I mean, at least we get some reimbursement. It'll be about 53 cents on the dollar.
Yeah,
but,
not enough, but
yeah, but it's better than nothing.
better than nothing.
Yes,
Okay,
absolutely.
thank you.
And Senator Titus?
Thank you. Thank you, Mr. Chair, for the question, and thank you for being here today. At what point does it become not sustainable? And the point I'm bringing up is, if I in this committee and in others I've been on, it's not, healthcare is not like the Walmart model, where you can buy a bunch of batteries from China and pay, pennies on the dollar for them. And if you sell millions of batteries, at some point you're going to make a profit. If you continue to get 43 cents on the dollar, and you think you can charge private insurance companies to compensate for that, at some point, you won't be able to sustain, the private insurance even will not be able to sustain, to reimburse you enough to keep your doors open. Right now, did you say a third of you said, 75% of the costs are now shifted to Medicare or Medicaid in Nevada?
Well, Senator, what I said was that 75% of our patients are subsidized by basically commercial insurance.
Correct. And so how long is that sustainable for commercial insurances to subsidize 75% of our population?
Well, I think that's where people get frustrated because they see their health insurance premiums going up, and it's because these programs aren't covering the cost.
I would say that we use a term, if I might continue, Mr. Chair, we use a term, the underinsured. Because I have patients that have insurance, but they can't get health care because they're waiting 3 months for their health care. They can't get into a doctor's office, or even worse, they have a $5,000 or maybe now even a $10,000 deductible. So these folks have insurance, but they don't have care. And so I'm just worrying that we're tipping the balance to such a point where pretty soon we won't have any health care in Nevada because no office can stay open. I used to tell my patients, my Medicare patients, that it's cheaper for me to have you stay home than for you to come and see me in my office, because I lose money every time I see you in my office. So just call me on the phone, would you? Or see me in the grocery store. Come by my house, something. Because if you walk in my office, it costs me money. And so they would get that aha moment then about what that disparity is. So anyway, I appreciate your being here today in the presentation. And one other clarity, if I might. What percent, again, for clarification, of folks were eligible for Medicaid or the Silver State Exchange that never applied, that you then have to help them with that? Do you have any idea about what percent of the population?
It was 83% of the uninsured Nevadans.
Were eligible.
They were eligible.
And they just didn't, for whatever reason, apply.
A lot of times it's because it's young, healthy people.
All right. Thank you, Mr. Chair, for the questions.
Thank you so much. Just one last question. So, because I work in health administration, I always keep track of utilization management, et cetera, and how the delivery of healthcare services actually are currently. This is the last question. You work with hospital executives day to day. You hear from them. You know the outcomes that our emergency rooms are dealing with. Would you agree that the best possible scenario for many of these patients that go to the emergency room perhaps is to get them access to preventive health care so that they don't have to go to the emergency room? Is that the outcome that perhaps would probably make the most sense for uncompensated care.
I think that if you were looking to save money, that makes absolute sense.
Thank you so much. That concludes our round of questions, and we'll go ahead and conclude this presentation. So
Thank
appreciate
you
it.
very much. Thank you for the opportunity.
All right, at this time, I'll go ahead and turn the gavel over to Vice Chair Nguyen.
Thank you. And at this time, I will now open the hearing on Senate Bill 419, which relates to public health. I'm obviously going to allow our chair to and his co-presenters to proceed when they are ready and make their way to the front table. So if you are presenting with Senator Donyate, if you could please come to the front table, that would be great. And please begin when you're ready.
Thank you, Vice Chair Nguyen, and good afternoon to the members of the Senate Committee on Health and Human Services. For the record, my name is Fabian Donyate, and I represent Senate District 10 in the heart of Las Vegas. I come before you today to speak on Senate Bill 419, which is an expansive piece of legislation that will make various reforms to our healthcare system. Today's presentation is historic. Over the last few years, many of us in the healthcare community have worked and dreamed about this moment. A moment that has taken away too long to address, a moment that is encompassing of the challenges that we have faced as a society. No Nevadan is left behind, no one is forgotten. In the very first week of the legislative session, I mentioned my intent to introduce legislation that would reform our healthcare system to better reflect and serve the individuals of this state. For too long, we've heard the horror stories in our community from the folks that have been consistently denied care. There's not enough doctors. I can't get on my doctor's schedule. I have to travel out of state to receive the care that I need. Healthcare is too expensive. I lost my home because of the bills for my care. Today, myself and other community leaders, physicians, executives, and folks representing the community are embarking on a piece of legislation that will shape the future trajectory of healthcare in our state, and it's one of which I truly believe can help establish a simple vision, and that's this. Everyone deserves access to care, regardless of who they are, where they come from, or their immigration status. For this presentation, I am joined by Ms. Tanya Gonzalez, a fellow with the Nevada Latino Legislative Caucus, and members of our clinical workforce. Tanya and I will spend a few moments talking about the bill in its conception, and then we'll talk about, she'll go ahead and explain the Medicaid expansion piece. This is the first part of the presentation that I want committee members to look at. I wanted to start off this presentation with this powerful photo, a photo that was taken amidst the COVID-19 pandemic. The Las Vegas Strip closed for business. As you look at this photo, I ask you to think about some of the words that come to mind for you and how this visual makes you feel. I'll go first. Shocking, absurd, confused, worried, frustrated, desperation, sadness, depression, hopelessness. Every day that I'm in this building, I think about this photo. I think about the thousands of workers that were laid off because of our broken public health system. I think about the time I had to fill out my dad's unemployment form, refreshing webpage over and over and over and over again, because that was the only way that we knew, and we wouldn't know how we would survive if we couldn't. I think about our state. I think about what we could have done, what we should have done to prevent this. I think about our country. I think about what we could have done to bolster our public health system with the right tools to prevent disease transmission. I think about the Nevadans that lost their lives, the families that unexpectedly found themselves having to bury their relatives because we didn't have the courage to build the right capacity or fund the resources to prevent this. I think about our healthcare workers and the indentations left behind around their sockets of their eyes from the surgical masks that they wore for hours because we couldn't dispose of them. Otherwise, we wouldn't have the resources to replace it. I think about this photo a lot, all of the time. It's what keeps me up at night, wondering where we went wrong and where we could go next. We've seen the statistics. We know that there were people in this community, in this state, that were left behind, including my family members, that were not treated equally. Whether it was the dissemination of health information or even as something as basic as healthcare coverage, people were left behind, and we continue to turn a blind eye on the hardworking families that call this great state their home. This photo is a reflection of how we failed, and part of today's bill hearing is to never repeat this ever again. You know, for too long, residents in my district have pleaded for help, and archaic policies both in this state and federally have denied people the right to live and access healthcare. We believe this bill is an appropriate way to repair our broken system, and here's how we'll get it done. So, if you're like me, you're probably sitting down July 2021 thinking, what on earth can we do to fix our healthcare system? So like any normal human being, as a health administrator that I am, I created a SWOT analysis. So I'm going to walk through some of the things that what I had visualized with our healthcare system. So the strengths, what does Nevada do right when it comes to our healthcare system? You know, I think we have a really strong tax base and incentives to encourage people, you know, to move into the state just in general. I think that is something that has always attracted folks to come here. Also, you know, the commercial insurance plans, as we heard earlier today, have a strong base too. We know that there are folks in this community that have subsidized others, and you know, in general, I believe we are approaching a level of maturity where our healthcare system is beginning to become more innovative. Weaknesses, what does Nevada lack and what don't we do well? Well, first, we lack sustainable public health funding. We've seen the statistics. Our state ranks last with public health spending, and that's part of the reason why myself and my other classmates couldn't find a public health job upon graduation. Because the majority of our healthcare providers are for-profit, you can argue that our systems in place right now are siloed. I don't want to play into that debate. I think the reality is we have failed to deliver on multiple things like interoperability and the current structure that how it exists to be today. And of course, we know that increasing our Medicaid reimbursement rate is an issue that needs to be immediately addressed to find sustainable funding models. Threats. What are the threats that could potentially leave permanent damage to our healthcare system that is already so fragile? Well, to start off, as we had presented earlier to this, we have a rising level of uncompensated care. Because of the nature of our federal government, we know that there are folks that have lived here for years, decades, that have been denied adequate care. There's no clear strategy to bolster our healthcare capacity, which has resulted in the workforce shortages that we see on the front lines of our healthcare system. We are always shorthanded. We look at placing bandages on our wounds instead of focusing to prevent the injury in the first place. And as a healthcare administrator that worked on the east side, I have interacted with patients that have been denied basic preventive services. Our undocumented immigrant population, including my family, have been denied the ability to receive adequate health coverage due to the lack of access to care. We deserve a system that takes care of everyone, but if you continue down this way, the problem will worsen and more lives will be lost. It's as simple as that. Opportunities. Here's the portion of this analysis that gives me the most excitement on where we can go. The digital frontier. Our ability to reform our payment models to incorporate technology into medicine and build the infrastructure to review, finance, and invest in the future products of tomorrow. The race for digital health is a national conversation that can pivot our state as an international leader, and that's why we spent time in this committee talking from HIMSS earlier this session. And further, I believe an effort to help diversify our economy is to attract more researchers to the state that could invest in biotechnology. If we build the right infrastructure, Nevada can be a leader in producing the next cure of tomorrow. And last but not least, we need to do our part to invest in graduate medical education and clinical programs. This is the opportunity that we have before us, and we need to do a better job at financing these initiatives once and for all. And so let me leave you with one thought. How do we do it all? How do we address the shortages, cover folks who need help the most, build on our interoperability, and pave the way to expand healthcare for people who have been denied? That's the HOPE Act. That's what we're here for today. The Nevada Health Opportunities Planning and Expansion Act of 2023, or for short, the HOPE Act, is a bill that brings forth the necessary changes in our community to provide preventive services and reduce the level of uncompensated care. It's an innovative bill that looks at the economic development trajectory of our state to build on our healthcare capacity and incorporate health information technology unlike ever before. This bill will set our state up for future generations to come, and it's one that I'm most proud to introduce as your colleague, but also as a resident that believes in our state so dearly. A state that deserves endless support and admiration, but that support and admiration must come with a commitment to change. Nevada's HOPE Act aims to do the following. Number one, align our health systems to be a leader in the 21st century. We know that patients deserve access to their data at any time, and that's what we're going to be covering today. Number two, shape the future jobs of tomorrow. I mentioned my intent to help modernize our public health system. We know that this has been a request for many folks throughout this community, and we also have to find new innovative ways to collaborate with one another. We're going to talk about later today about the Nevada Innovation Hub, which is going to be a state-ran entity that can help the collection of public health data that the government already collects and making sure that we're all aligned together and not duplicating services. Further, I think we should have the conversation as to what digital health reimbursement looks like. And last, number three, building our healthcare capacity. Nevadans should not be forced to go out of state to receive the care that they need. We need more doctors and more facilities. I firmly believe that investing in healthcare jobs is a good financial investment for the long-term sustainability of our state. This bill will work on introducing a new tax abatement program to allow medium and large health industries to move into the state and support our general infrastructure. And then number four, expand access to healthcare for all Nevadans. Historically, we know that people have been left behind, and each of these initiatives reflected in the bill context. We'll go ahead and break it down for you so it makes it easier to follow throughout the bill. Aligning our healthcare delivery systems together. SB 419 establishes two principles: building our capacity for data interoperability and aligning ourselves toward the Trusted Exchange Framework and Common Agreement, known as TEFCA. Under Section 6 of the bill as drafted, it would require DHHS, in consultation with our healthcare providers and third parties, to prescribe a framework for the electronic maintenance, transmittal, and exchange of health electronic records. TEFCA is an item that was mentioned earlier this session from HIMSS during their presentation. And it's part of the work that is being fulfilled by the National Coordinator of Health IT. Essentially, under the 21st Century Cures Act, the National Coordinator of HIT is charged to develop a trusted exchange framework and a common agreement for health information networks nationally. And in January 2018, ONC began the process of releasing drafts of what we know today as TEFCA. Primarily, the goal of TEFCA is to establish a universal floor of interoperability across this country. Under some of the guidelines established by TEFCA, there are a few outline principles. TEFCA seeks to accomplish the following: the standardization of health data, openness and transparency, cooperation and non-discrimination, privacy, security, safety, access, and equity. To help you understand what TEFCA entails, I am going to describe a few contextual definitions. When the National Coordinator of Health IT received the go-ahead to begin this trusted exchange process with the passage of the Cures Act, they quickly identified a recognized coordinated entity. You might hear me say RCE. A recognized coordinated entity, or what has been identified as a Sequoia project, will help develop, update, implement, and maintain the common agreement that providers will participate in. It is responsible for soliciting and reviewing applications of qualified health information networks. And I'm sure you're probably thinking, what the heck is a Qualified Health Information Network? A Qualified Health Information Network, or QHIN, is a regionally affiliated network that agrees to the common terms and the conditions of exchange. QHINs will be the central connection points when the TEFCA ecosystem is set up, as they will help states route queries, responses, and messages amongst entities and individuals. And to help close out any potential questions that may arise, TEFCA creates a common agreement, which is a document that will provide the governing approach necessary to scale the interconnections of QHINs throughout this country. The common agreement will allow healthcare providers to coordinate with one another and build our interoperability of data. Federal standards will begin to require alignment. Nevada's participation will put our state as a model of implementation for this conversation. Here's a quick timeline of where TEFCA currently is. You can see from this graphic that the Sequoia project has already released a list of the first approved regional QHINs, and they will begin to launch TEFCA-based exchanges fairly soon. Later on this year, the federal government will continue to process applications for other QHINs to refine some of the language for the common agreement to be utilized by states. I want to pause here because I know this is a point of contention and it's important for me to reiterate what this bill does not aim to accomplish. TEFCA is not a network. It's not a technical standards body, a technology, a platform, or a data service. SB 419 allows DHHS with the ability to begin prescribing regulations on the items set above, which will include the necessary requirements to align toward federal standards and bring together our local health providers. And before I move on, I want to make a quick point of clarification. My intent in Section 6 is not for the state to create our own standards of interoperability. That would be counterintuitive to this process. My goal is to ensure our state is aligned toward what is being accomplished federally with TEFCA. We should not be creating more regulatory burdens that already exist and should instead prioritize the initiatives our federal government will seek to address. Further, I'll point on this later, we do have a conceptual amendment that makes conforming changes to various sections, including Section 1 and Section 6 of this bill, with regard to jurisdictions and compliance. So we'll touch point that later today. On this slide, I have provided a graphic to help introduce you what a QHIN looks like and how the information is distributed amongst institutions. So the RCE, the Sequoia Project, is the main entity facilitating the transmittal of digital health information. The QHINs are the mediators between the different regions across the country. Participants of the QHIN can be centrally based repositories, health information exchanges, or state-based utilities. And then sub-participants in this graphic could be individual entities like UMC or other hospital systems that operate in multiple jurisdictions but need the flow of the data to one centralized QHIN. Further, SB 419 establishes requirements for an EHR integration. To continue our commitment to prioritize the interoperability of health information, this bill will require that government entities, health providers, and administrators adhere to maintain, transmit, and exchange health information with an EHR system. The deadlines are set here on this slide. Requiring providers to integrate with an EHR is not only a good practice to assist patients in relation to their health data, but it's also a cost savings measure that can reduce the duplication of procedures. Senate Bill 57 will appropriate general fund dollars to help smaller providers and doctors comply with this requirement. And Section 6 of this bill also establishes a waiver that helps providers that may experience difficulty with the interoperability requirements set forth in this provision. The reference that we have is infrastructure waiver. So if you're in an area that doesn't have broadband technology, you shouldn't be required to obligate with these regulations because obviously you can't connect to the internet to begin with. Senate Bill 419 will allow DHHS to understand where providers stand with the facilitation of their health records to essentially get the lay of the land, which can help us understand where to spend future dollars on broadband and interoperability should federal grants become available with TEFCA and other pieces of legislation. Shaping the future public health jobs of tomorrow. Throughout the COVID-19 pandemic, we know that our state fell behind with regard to health information technology. Earlier this session, you heard from our public health professionals themselves that in the initial stages of the pandemic, everything was being traced through an Excel spreadsheet. As a state, we can do better. We deserve data points that actually work, and the reality is we're already doing this work. That is why, to build the future health jobs of tomorrow, we need to enable the full reimbursement of digital health and begin to modernize our outdated public health systems. Under the provisions of this bill, the Joint Interim HHS Committee will begin to explore the full reimbursement of digital health. We had presentations in this committee as to what this could look like, and it's going to cost, some financial circumstances later on. We need to start the process now as to what that could look like. Artificial intelligence is already mainstream in healthcare. Fun fact, I use artificial intelligence to help write my remarks today. It's part of our natural being. It's happening already. You can see in this quote from a peer-reviewed research study, CMS is already beginning to establish a national payment around an authorized artificial intelligence system that can help make clinical decisions and support the expansion of healthcare delivery. Further, we will increase the use of AI in virtual reality. The American Medical Association has already unveiled new CPT codes for these services, including artificial intelligence and virtual reality. Senate Bill 419 requires the Joint Interim Committee to review the feasibility of the full expansion of digital health, including remote patient monitoring and digital therapeutics. And as someone who has worked in this space, it is my belief that Nevada has the opportunity to begin revising our payment models to be more encompassing of technology. It can lead us as a way to be innovative and can begin to build an infrastructure cycle of research, qualification, verification, investment, and commercialization. Modernizing our public health system. Over and over again, we've heard from constituents and public health officials the lack of capacity for our state to carry the transmission of public health data. Let's be clear, public health data is already being collected by our different state agencies and departments, but because of the nature of siloing work, the systems fail to connect with one another, and that allows us not to be able to create evidence-based strategies to address social determinants. Section 22 through 24 of this bill will establish the Nevada Innovation Hub. Modeled after the Indiana Management Performance Hub, the Nevada Innovation Hub will work to align our governmental public health systems to better work alongside one another. SB 419 addresses the feedback collected by the SB 209 COVID-19 study, which emphasized the lack of coordination between jurisdictions. The Innovation Hub can become a home for public-private partnerships to be established and finally eliminate the disparities that we have seen based on the social determinants of health. And to make a quick clarification on the intent of the hub, my ultimate goal is to delineate the outcomes of this hub toward public health data, not healthcare-related data. The hub should not be a resource that can provide for the coordination between different agencies and jurisdictions to improve outcomes. It's part of the data points that our state already collects for varying reporting requirements. For instance, I see the hub taking on issues like the opioid epidemic, or working with the Nevada Department of Education to address social determinants with support of income data generated by our school forms. We can work together to solve major systemic issues with the data already collected. The goal should be not to work in silos, but to provide an enhanced level of strategy. This isn't a hub for healthcare-related data on prescriptions you're taking or how your physical went. That's a separate conversation for another session. Most importantly, the hub must align toward the de-identifiable data points. We want to ensure that patients continue to retain their privacy and that it is secured and that we oblige by the federal standards established by HIPAA, which is why this bill aligns towards this initiative. And lastly, my ultimate vision for this hub. Throughout the COVID-19 study, we heard stakeholders saying that we failed to coordinate between different jurisdictions. The reality is that most of this will come down to money and resources, but we deserve a health official in the state that can help provide us some level of strategic direction on bringing everyone together for public health related data. Ultimately, we want to ensure that Nevada is positioned to take on grants from the CDC and other national groups to pilot new initiatives to modernize public health reporting structures in a scalable, sustainable way. Nevada can lead in that way rather than creating a singular solution, and that will set us up to succeed in the long run because public health data on patients should cross boundaries and our systems should work together. And lastly, Section 59 is perhaps one of the most important portions of this bill. Throughout the COVID-19 pandemic, the staff at DHHS have been relentlessly serving our population to help navigate this public health emergency. Now that we are in the recovery stage, it's time for DHHS to begin studying determining, adding, eliminating, reclassifying, or revising the salary for positions to either increase the effectiveness or efficiency of their state operations. Building our healthcare capacity and diversifying our economy. Throughout the campaign cycle, voters reiterated to me their frustration with coordination of our healthcare system and the lack of providers. We can do a better job to attract more companies to the state, and I firmly believe in bioscience as the ability to help drive Nevada's economy forward. Although we anticipate this bill to be referred to the Senate Committee on Revenue and Economic Development, that is something that we potentially could occur to review the contents of the abatements. I will quickly go over some of the adjustments that were made here in this bill. Sections 31 through 38 of this bill provide for the abatement of sales and use taxes for property to provide healthcare or conduct scientific research, certain property taxes imposed on businesses, and an excise tax on wages paid to employees performing services directly related to addressing critical medical and scientific needs. With an ever-changing pandemic, Nevada has shown its resilience with countering public health disasters. Now more than ever, Nevada needs to diversify its economy. Senate Bill 419 will enable the Governor's Office of Economic Development to attract new health startups and businesses seeking to find the next cure. And at this point, I'll go ahead and turn it over to Ms. Gonzalez, who will share with you the last portion of this bill, which is to ensure all Nevadans receive the care that they need.
I remind you to press the button. Thanks.
Thank you. Thank you, Senator Doñate, and good afternoon, Vice Chair Wen, and members of the Senate Committee on Health and Human Services. For the record, my name is Tanya Gonzalez, and I'm a fellow for the Nevada Latino Legislative Caucus. I want to speak to you all today about the lessons we have learned since the onset of the COVID-19 pandemic, and the strategies other states have continuously taken to combat the lack of access to healthcare issues. So today, I will quickly go over expanding access to healthcare to all Nevadans, the impact of COVID-19, similar legislation in other states in tandem with their outcomes, and I will conclude with a holistic bill summary. Now, the Nevada HOPE Act, SB 419, is an act that relates to all Nevadans, arguably everyone in this room. Nevadans need health care. Expanding access to health care is more than fiscally responsible. It is the right thing to do. So that is why, through Nevada's HOPE Act, we are introducing legislation for a Medicaid expansion for all Nevadans, regardless of their citizenship status. So in such manner, it will become Nevada public policy that each resident of the state who would otherwise be eligible for Medicaid, if not for their non-citizenship status, may enroll in Medicaid. So sections 39 through 49 pertain to this. So it is indisputable that Nevada took a hit from the COVID-19 pandemic. The uninsured crisis left Nevada uniquely vulnerable to the pandemic. And as a result, communities of color were disproportionately affected. Nevada's racial and ethnic minorities were among the hardest hit by the pandemic in terms of infection, hospitalization, and mortality rates. So according to a study that is an exhibit, roughly 40% of COVID-19 deaths in Nevada were linked to health insurance gaps. And more than 50% of all COVID-19 infections in Nevada were also associated with health insurance gaps. So now this is a shocking statistic because it means that those deaths could have potentially been prevented if access to care perhaps had been more accessible. So currently, Nevada has an estimated 330,000 uninsured individuals, signifying 10.6% of the total state population. This data is from the recently published 2023 Insurance Market Report, and you could see it circled in red. So now, out of the aforementioned uninsured amount, 27% was the total of uninsured Nevadans for 2019 who were ineligible because of their immigration status. Circled in red again. So following that year, in 2022, the percentage slightly increased to 34.9%, as displayed on the table. So lastly, here is a visual that displays and adds to that information. The total number of native-born citizens in Nevada is around 241,000 people, so which represents 60.6% of the uninsured population. So now this is depicted by the purple on the right. So this combined with the natural foreign-born population amounts to 67.6% of the uninsured. So now what does this mean? This means that 1 in 3 uninsured individuals in Nevada are non-citizen foreign-born. So that said, while 10.5% of the total Nevada population is uninsured, almost half, 1 in 2 of non-citizens are uninsured. So now this is where the 44.2% come from. So using this data, we estimate the Nevada HOPE Act will obtain an enrollment of 95,000 to 110,000 Nevadans. So displayed in the graph, so the graph illustrates the American states that as of 2022 have passed legislation to expand and to combat, to expand and to commit to health equity. So this is not including the recent passage of Colorado. So highlighted in red, currently 9 states provide comprehensive state-funded coverage to all income-eligible children, regardless of citizenship status. Those states are California, Illinois, Oregon, Colorado, Washington, D.C., Maine, New York, Rhode Island, and Vermont. Another 10 states in light blue have used the federal Children's Health Insurance Program to expand access to children. So some states in the mixture of 2 have also expanded to women who are pregnant. Shown now is a timeline of the Healthy Illinois campaign. So 7 years ago, Illinois first guaranteed coverage to all kids up to age 19. In 2020, Illinois expanded coverage for non-citizens, seniors 65 and older. Each year after that, Illinois expanded coverage to more groups. So ages 55 through 64, ages 42 to 54, and more recently, in 2023, Illinois closed the gap, ensuring non-citizens ages 19 to 41. So here is a table that displays the precise enrollment numbers within each group population. I will pause so that you can take a look at it. So please note that year after year, children are the most enrolled. Now this is California's timeline. In the same year as Illinois, 2016, California established its Medi-Cal program, guaranteeing coverage to all kids who are non-citizens up to age 19. Like Illinois, California expanded coverage to different age ranges in 2020. And each year after that, closing all health insurance gaps just last year. Again, last year, California closed its last insurance gap. So on the right, you'll see the uninsured rate for Californians, 0 to 64 before, and after the last Medicaid expansion to non-citizens, which the group was ages 26 through 49. So where I'm talking about the graph displayed on the right. Sorry. So you can see that the undocumented category significantly dropped by 30%. So that's the green 54 to 27% approximately. Now on the left side is a collective look at California's enrollment expansion since the start of their campaign. Lastly, here's a graph synopsis of the aforementioned declining rates. So you can see the yellow Medi-Cal line increasing, whereas the blue uninsured line decreasing, and they diverged. So moving on to Oregon, so Oregon first guaranteed coverage to all kids who are non-citizens up to age 19 as well. And a couple years after its implementation, it expanded to young adults ages 19 through 25 and seniors 55 and older. So Oregon, like other states, experienced a steady incline in enrollment month by month. I'll take another pause so you guys could take a look at it. So within those enrolled, there was a wide range of health care sought. So starting with primary care and specialty care, followed by dental care, pharmacy, and so on. So displayed are the categories. Now the last state that I will cover today is Colorado. Last year, it too began by covering income-eligible kids who are non-citizens. At the same time, it expanded coverage to women who are pregnant and up to 12 months postpartum. So with this, they targeted the significant health care disparity between Hispanic women and non-Hispanic white women, which is shown on the left of the slide. Now displayed is the multiplier effect that Colorado assessed. So this is applicable to other previously mentioned states as well. So the idea is that if money is injected to expand Medicaid, then that will carry on to a new increased state economic activity. So I hope that by now, in addition to seeing a trend among the states, you are able to see the strategy that other states have continuously taken to combat the lack of access to care issues. That said, this strategy helps reduce health disparities. The states I spoke to you about today have seen healthier birth weights with lower risks of infant mortality, reductions of maternal mortality rates, higher rates of adolescent immunizations, lower rates of emergency room visits, less admissions for health issues that could have been prevented, and simply just more preventative care. So I will conclude with a brief bill summary. Section 6 28, 29, 45, and 63 require the establishment of a framework for the interoperability of health systems and mandates the commencement of usage to be July of 2024 and 2025. Section 57 appropriates grants to assist with such compliance. Section 60 requires a director to establish an advisory group. Sections 2, 6, and 1 mandate notice of failure to comply and sets an opportunity to be heard. So it's important to know that this will not be a misdemeanor. Sections 9, 17, 45, 47, 50, and 53 have now been stricken. They required the suspension of credential upon notice. So sections 15, 49, and 54 have also been stricken. They
Can you say
established
what section that was again?
the 19, 17, 45, 47, 50, and 53. I believe it's in the second row.
Thank you.
Next, sections 15, 49, and 54 have also been stricken. They establish that the suspension is not subject, which formally established that the suspension was not subject to procedures such as suspension as licenses. So it was a different type of certification suspension. And then the next sections 1, 9, 17, 45, 47, 50, and 53 required reinstatement of the suspension of credentials if the holder complied. So again, this language has been stricken. And lastly, on this slide, Section 4 authorizes the director to establish a statewide health information exchange. Section 7 expands healthcare immunity from liability to providers who use the interoperability system. Section 8 establishes that the exchange of electronic health practice is not an unfair trade practice. Sections 22 through 24 establish that the Nevada Innovation Hub establishes the Nevada Innovation Hub with the Department of Health and Human Services. Section 23 creates the position of the Chief Data Officer to serve as the executive of the hub and to advise public health agencies. Section 24 requires that the hub establishes and maintains its activity. Additionally, Section 24 and 27 requires that the confidentiality of personal identifiable information maintained by the hub, for which disclosure is prohibited. And Section 61 has also been completely stricken. It required the Chief Data Officer to submit a report to the Joint Interim Standing Committee on the hub's policies and procedures. So next, Section 31 authorizes partial abatement of healthcare or scientific research and certain taxes, and also requires the applicant to obtain the approval of a supermajority from the Board of Economic Development. Sections 35, 36, 37 establish the duration and amount of the abatements. Section 38 authorizes abatements on certain machinery. Section 39 requires a director to authorize Medicaid in the state plan for any person who otherwise qualifies regardless of their citizenship status, but now has been amended to require the state to first seek federal waivers from the federal government to seek financial participation. Section 49 removes the requirement that a person who is not a citizen must be allowed by federal law to receive Medicaid. Section 41 creates the Medicaid Advisory Committee within the division. Section 42 requires the committee to advise the department and publish a report of its activities. Section 59, requires the department to assess the workforce development and submit a legislative report thereafter. Last but not least, I present the 3 conceptual amendments that were made today. So I've briefly gone over them. So any licensure or revocation penalties have been completely stricken. So any licensee that fails to comply with the interoperability regulations and standards are instead now going to be referred to an appropriate regulatory body. The requirement that the Chief Data Officer submits a report to the Joint Interim Standing Committee on the Hub's policies and procedures is also stricken. And lastly, the director is newly required to first apply for any federal waivers or to take any other actions necessary to obtain federal financial participation for the Medicaid expansion. So was it. So as you can see, the Nevada HOPE Act will provide reforms on the interoperability of health data and provide incentives to build our healthcare capacity, which includes the full Medicaid expansion of all Nevadans who would otherwise qualify. So it is the right time to do so. It is the right thing to do. So just please help us pave the way for Nevada to be a national leader in the space of health infrastructure and access to care. Thank you.
Thank you so much, Tanya. Fabian Doñate for the record. Vice Chair Nguyen, I do have other presenters that will help me with this bill that will touch point on some of their personal experiences as health professionals in our state. A few things to note before I turn it over to our speakers. As you will hear today, there is broad statewide support for this proposal. Nevadans are already fronting the bill as the levels of uncompensated care continue to increase. But rather than hearing it from me, I want you to hear it from our healthcare providers. So to start us off, I do have 2 folks. So I have with me Mr. Todd Slamberg, the Chief Executive Officer of Sunrise Hospital, and then we also have Dr. John Hardwick, who is an emergency medicine physician at Renown Health. So, Dr. Hardwick.
Can you guys all hear me okay? Oh, yeah. All right. So my name's John Hardwick. Thank you so much for inviting me, Chair and Committee. So I am here, I think, to add context to the conversation. I worked today, I started work at 4 a.m., got off my shift, and immediately came down here because I think this is an incredibly important issue that needs to be addressed. As an emergency physician, a lot of us went into this because we want to care for the sickest and most vulnerable in our community. And it allows us as a safety net to see when the system is broken. Currently, the current paradigm of healthcare reimbursement results in multiple consequences when it comes to the underinsured and the uninsured. One that has already been, I think, brought up very eloquently is that patients seek primary care at the emergency department. So what happens in these cases is, let's say you have a diabetic, right? Someone comes in, they have a history of diabetes. They come in, maybe they don't know they have diabetes, and we diagnose them with that in the emergency department. I might be able to start them on some oral medication, but my ability to offer longitudinal care is very, very difficult, right? And longitudinal care, especially in chronic illness, is incredibly important because it's very important to monitor that disease. How is that disease progressing? How are they responding to the medication? And without that, overwhelmingly, these patients have a decompensation of their disease, and ultimately it leads to worse outcome for that patient and more expensive care. So let's say you have a diabetic patient who doesn't seek or seeks care. They don't have follow-up. What happens to that patient? Let's say they develop a diabetic foot ulcer, right? That diabetic foot ulcer ends up becoming infected. They have to come back in. They lose their foot, right? That's an expensive procedure. That's an expensive hospitalization. And then you have someone who's now outside of the workforce who can no longer work. Senator Stone, you made I think a question about EMTALA, right? What happens if we had to treat every single hangnail that came to the emergency department? Currently, we do have to treat every single hangnail that comes to the emergency department, and we're very happy to do it. But it's, like was mentioned earlier, it's an incredibly expensive and inefficient way to do that care. So just earlier this morning, right, I took care of an ingrown toenail, right? And I'm, again, happy to do it, but it's much better employed through a primary care physician. But they came to me because they were unable to get that care at an urgent care or at a primary care physician's office because they did not have insurance, right? And so when we talk about the cost of these things, right, we talk about, there's some talk about it being parity, right? Oh, well, if we're already paying for this in the emergency department and therefore, it justifies the cost. We're not only paying for it, we're paying more right now. Right, we're paying significantly more because these diseases progress, and these patients' diseases progress to a point to where the care costs significantly more. Right, if we can intervene in a chronic disease, it's significantly better to intervene in that chronic disease early before it progresses. Another thing that happens is patients avoid care altogether because they're worried about the cost associated with it. Right, people want to pay their bills. And they're worried about going to the emergency department because the cost associated with the emergency department if they're underinsured or uninsured. What happens in those cases, I saw a very tragic case very recently. A gentleman came in, he had a squamous cell carcinoma. Squamous cell carcinoma is a very simple cancer, a skin cancer. Often, many people have had it. It's very simply treated by just doing a quick excision of the lesion, right, overwhelmingly. But this gentleman didn't have a primary care doctor. He didn't seek care. The lesion got worse. The lesion got worse. The lesion got worse. And by the time he saw me, it had invaded into his entire orbit. He lost his eye. And by the time he was in the emergency department, he was having intractable seizures. He was in a coma, and he was intubated, placed in the ICU. And you can imagine the cost associated with that, right? Not only the societal cost and the cost for that individual, just from, but also the monetary cost of that patient, and not having a system in place that that patient was able to seek reliable care. Another issue with this is that without reliable reimbursement for this, and as our undocumented population grows, right, this has already been said, I think, very eloquently before, but that cost is passed through to other payers, including state Medicaid programs. So basically, we're paying for it anyway as a state. And also, one way that hospitals have to address this, right? They can't go insolvent, right? They have they want to serve the community, but that means they have to cut staffing. They have to cut services. That means more physician burnout. That means more provider burnout. That means less services available for your mammograms, for your routine care, right? And so it's this kind of it perpetuates the cycle that basically everything just gets worse if we don't intervene early. And lastly, it leads to us not being able to provide meaningful follow-up for specialty services. So, we'll have a patient come in, and let's say they come in, they have something called SVT, where your heart rate just goes super, super fast out of nowhere, right? And that's something that we can treat in the emergency department with medications or cardioversion, right? So we shock them, right? You can imagine those medications are not cheap, and monitoring those patients is not cheap. And those patients, there's a simple fix, right? They can get an ablation, but that happens as an outpatient. Ablation is a procedure where a cardiologist can go in there and just kind of burn that area of tissue in the heart that's just a little hyperactive. But without that, the patient's discharged, they don't have a reliable means of follow-up, and so they keep coming back, and they keep coming back, and they keep coming back. And so this is a problem that could be fixed with one visit to a specialist, but they're unable to see that specialist. And therefore, the ER recidivism keeps coming back and back and back. And so you can imagine that this is a cost that just perpetually increases. With that, I'll take any questions. And again, I really thank you all for having me and letting me speak.
Good afternoon, Vice Chair Wynn and members of the committee. My name is Todd Sklamberg. I have the privilege of being CEO at Sunrise Hospital and Sunrise Children's Hospital for the last 15 years. And I appreciate the opportunity to spend a couple of minutes with you. First, I do want to thank Senator Donyate for selecting a picture which eliminated my gray hair and my balding spot. So appreciate that, Senator. But we do thank the Senator for working on the HIE provisions to ensure that Nevada is at the forefront for the exciting advancements in the interoperability of patient health records aligned with the national standards. And we also commend the Senator for opening the important conversation on the expansion of access for care. Let me just spend a moment sharing a little bit about Sunrise Hospital and one or two quick examples. Sunrise Hospital is the state's largest acute care hospital at 834 beds. We have the privilege of treating over 250,000 patients each year, 175,000 coming through our emergency department, 40,000 admissions. We also have the privilege of being the state's largest Medicaid provider. 1 in 5 Medicaid recipients in the state of Nevada receive their hospital-based care at Sunrise Hospital. 1 in 4 in Las Vegas receive their care at Sunrise Hospital. And we are committed to all patients, regardless of their ability to pay and their residency status. We care for the entire community. About an hour ago, when I touched base with the hospital, we had 850 patients in our hospital, admitted patients. Okay? We had an ER of almost 200 in the hospital. Each year, we care for over 2,000 undocumented patients each and every year coming through our hospital. Many of you have had the opportunity to tour our hospital and spend some time in Sunrise Children's Hospital and specifically our neonatal intensive care unit. And there's no better place to understand the impact of preventative care and access to health care than touring our neonatal intensive care unit. Okay? Just last week when I was up in the unit, I had the opportunity to visit a 500-gram baby. 500 grams is about a pound. So think about 4 sticks of butter. Okay? That's about a pound. Okay? That baby was born at 22 weeks. Okay? No coverage. Okay? Mom didn't have any prenatal care. Okay? So as we think about access to care and the provisions that we're talking about today, that ounce of prevention will provide significant enhancements for that baby. Instead of being in the neonatal intensive care unit for weeks, for 15 weeks, that individual would potentially lead a healthy life. The access to primary care, the access to obstetricians to get the prenatal care will help reduce admissions to one of the most costly and acute settings in a hospital, the neonatal intensive care unit. So as you contemplate the bill, please keep in mind that expanding coverage to include more of the uninsured is a strong investment. Most importantly, it increases access to preventative care, promotes overall wellness, and leads to significantly improvement quality of life. And today's hearing is just really the first step, in a voyage of expanding healthcare access and services. And we look forward to working with you, as this bill moves forward. Thank you.
Thank you so much, Todd. We'll move on to the next presenter for this bill. Next, I will go ahead and introduce Ms. Luz Castro from Dignity Health. She has a few slides that have been uploaded to Nellis, and she's attending virtually. So, Ms. Castro, please proceed.
Thank you, Senator. Thank you, Senator, members of the committee. Do you all hear me?
Please proceed.
Okay. For the record, my name is Luz Castro, and I am the program manager for Dignity Health St. Rose Dominican's Red Rose program. I want to thank you, Senator Doñate, for allowing us to present on our program and our work with the undocumented population of Southern Nevada. Dignity Health, St. Rose Dominican, started in 1947 after World War II. After the basic magnesium plan came to a close, 7 Adrian Dominican sisters of Michigan traveled to Henderson with Bishop Gorman to purchase the hospital for $1 a year for 25 years. The hospital purchase is today known as our Rose de Lima campus. We are the only not-for-profit faith-based hospital system here in Nevada. Our mission is we make the healing presence of God known in our world by improving the health of the people we serve, especially those who are vulnerable, while we advance social justice for all. It's our mission to serve our most vulnerable population, especially the uninsured, the underinsured, and the undocumented. Today, St. Rose has 3 main campuses and 4 neighborhood hospitals. As previously mentioned, at St. Rose, we are called to serve all vulnerable populations, and the Red Rose program is just one example of the type of care that we provide to the undocumented population. The Red Rose stands for Responsible Early Detection Program, began in 2001, founded by Sister Monica Stankus. She wanted to ensure that women without adequate insurance receive the treatment they need in their fight against breast cancer, as well as financial support if they cannot withhold down a job while receiving treatment. Then in 2018, the program received a transformational $10 million donation from the Las Vegas-based Engelstad Foundation to carry on this important work. The program was rededicated as the Engelstad Foundation Red Rose Program. So the Red Rose program supports vulnerable women and men with free breast health services if they are low income, if they're uninsured or undocumented. These services are clinical breast exams, mammograms, ultrasounds, biopsies, follow-up consultations, and surgeries. So since its inception, the Red Rose has cared for over 7,500 patients, providing 4,336 mammograms, 3,739 ultrasounds, 867 biopsies, and 130 breast cancer diagnoses. And 90% of our Red Rose clients are undocumented. Unfortunately, there is a lack of preventative healthcare services for the undocumented community. In Nevada, women with breast cancer who are uninsured need to pay out of pocket for their treatments like chemotherapy or radiation. And these out-of-pocket costs between $600 to $1,000 per treatment. This causes a financial burden for our clients and their families, forcing them to travel out of state in search of free or affordable treatments. Our clients have expressed to our navigators other health-related issues, and we strive to connect them to free programs at Dignity Health, but it's been challenging to find more community resources to support their needs. By expanding Medicaid to the undocumented community, we're not only giving them access to better quality of life, but it can mean saving someone's life. At Dignity Health, we believe that healthcare is a basic human right for everyone. Thank you, and I'm available for any questions.
Thank you so much, Luz. Phoebe Doñate for the record. Next, I will go ahead and introduce a few other clinical providers. We always have the question, well, why can't FQHCs cover this? So we have folks that can cover that answer. I'm honored to be joined by Dr. Jose Cucalon Calderon and Dr. Maria Fernandez from the Community Health Alliance, which is an FQHC in Northern Nevada.
For the record, I am not employed by the Community Health Alliance. I am a general pediatrician practicing in Northern Nevada for the last 6 years. If I take my name is Jose Cucalon Calderon, Jose, J-O-S-E, last name is a two-word last name, C-U-C-A-L-O-N, second word C-A-L-D-E-R-O-N. if I take time and pauses, it's because I'm actively translating Spanish to English in my head before it comes out, so I do apologize for that. I'm going to speak about stories that I encounter almost on a daily basis that become a lot more frequent during the initial couple of years of the pandemic. History of families coming to establishing with my practice and starting to talk about family situations that led to loved ones having either critical illness or death, of being unable to access healthcare services, including the parents of my patients. As a pediatrician, I see patients from birth until they are 21 years old. So that is a long continuum of and a long relationship that I have established with a lot of these families since I have been seeing their kids now for close to 6 years. As one of the very few Spanish-speaking physicians, especially pediatricians, families come to me with all sort of questions, asking about what choices are going to be good for their kids and good for their kids' development, their growth, and for them to thrive. And one of the more common answers that I talked about is, being able to make sure that you are taking care of yourselves, about being able to contract services, being able to get your colonoscopy, your mammogram on time, with answers that frequently turn to, I don't have a PCP. I don't have access to that. I am undocumented. I also run an extremely busy newborn nursery up here in Northern Nevada, where the care that we deliver to these newborns gets affected, not for the better, because of the lack of prenatal care and visits that mothers have during their pregnancy, which can lead to significant health consequences, just like was mentioned previously about when we talked about the NICU and NICU grads. Primary care is life. It can mean the life of your family, it can mean the life of multiple families. And access for everybody is something necessary, not only for all the right reasons. It's going to be cost effective, it's going to end up expanding access to care for everybody in the state, as well as allowing people to practice best medicine available, which is preventive care. Thank you.
Hello, my name is Maria Fernandez, and I'm a family medicine doctor at Community Health Alliance, which is an FQHC in Northern Nevada, a federally qualified health center. I come here in support of this bill. Thank you, Senator Doñate, for inviting me. As a family med doc, I see newborns all the way to my patients. I have a couple in the 90s. And as we know, as any primary care provider knows, that having access to insurance means that they will actually come and seek medical care before they end up in the emergency room. Like my emergency room doctor shared, I see a lot of the hospital discharges after they have had a leg amputation because of uncontrolled diabetes. I can control their diabetes, I can work with them, but the damage has been done. They entered the emergency room because they had other priorities. They were paying for food, they were supporting their family. And so absolutely, as an FQHC, we provide services, we do screening, we provide a lot of grant programs, but sometimes, because they do not have insurance, they don't come see us early enough. They just don't come in. Even with the slide, they come in and they haven't been screened for their cervical cancer, and they come in with cervical cancer. And so I would encourage you to think about this bill and the possibility of covering people with insurance and how much that would actually prevent in terms of complications, and how I could actually plug them into specialist services without them going bankrupt due to the cost. And so I take care of my patients as if they were my family members. And so I would absolutely, our Nevada community absolutely deserves to get access to healthcare and deserves insurance. So thank you for having me.
Thank you so much, Fabian Doñate, for the record. Next, I will go ahead and introduce two other speakers. I think this is probably the part of the presentation that hits the most home. I think it's important for you as committee members and as legislators to see the most extreme cases, because the reality is they're happening and we could do something to prevent it. So I have Ms. Annette Logan Parker, who's joining us virtually, and of course Kat, who's right next to me, and they will touch point on some of the extreme cases that we see with our kids in the Las Vegas Valley. So Annette, please proceed.
Annette, are you virtually or? Can we switch it up?
We'll switch, yeah.
Thank you so much. Thank you, Senator Doñate and Vice Chair and committee members for having me here today. The reason I'm here today is a very personal one. As a parent, it's of course our job to keep our children safe, to ensure that they are happy and healthy. What if in your search for a better life, you get thrown a curveball and you get sick? You want to survive, but the odds are stacked against you because you are undocumented, therefore uninsured. And to top it all off, you don't speak English. This situation happened to my own father. He arrived to this country with hopes and dreams, and tragically within months, we learned that he had an aggressive form of kidney cancer, and he needed surgery. Being undocumented and uninsured in Nevada means that you are alone with nowhere to turn. Go to the hospital, they say. They can't turn you away. Turns out they can, and turns out they did. My dad ended up having surgery months later, but only after we agreed to pay cash up front. We were forced to borrow money from friends and family, and we came up with the required $5,000 just to schedule the surgery. But unfortunately, we were too late. He died the day after the surgery. How could he continue to keep us safe? This happens every day right here in Nevada. After losing my dad, I was determined to help families just like mine. I am now the Director of Patient Experience at Cure for the Kids Foundation, and I see families like my own every single day. Our organization provides treatment and care for children battling cancer and other diseases. Do you know what happens when a child is diagnosed with cancer and the child and the parents are undocumented and uninsured? Imagine for a second the thought of your child dying because you cannot afford the treatment to keep them alive. It is heartbreaking to know that our state can't provide them with one of the most basic needs, which is healthcare. I want to share the story of an 18-year-old young lady named Azul. Actually, her picture is right over there. She's the one giving you the peace sign. I first met Azul when she was diagnosed with MDS, which is a rare form of blood cancer, when she was only 13 years old. Her mom recalls hearing Azul's diagnosis and thinking, okay, this is going to be hard, but we got this. As they navigated a very broken healthcare system, soon she realized that the hope of keeping her daughter alive was quickly fading. Being uninsured brought problems that they were not expecting. At every hospital visit, the social worker would have them reapply and reapply for emergency Medicaid. Every denial broke her heart all over again. Because guess what? Cancer is not emergent enough to qualify for emergency Medicaid. So she sat there and sat payment plan after payment plan and pay as much as she could. But still, one day, the unthinkable happened. They were denied entrance to the hospital for their inability to pay the full balance for her treatment. She was just 3 cycles away from finishing her chemotherapy treatment. Her family knew that stopping the chemotherapy early will increase her chances of not just relapsing, but dying tremendously. Her mom was desperate to save her daughter. She called TV stations, radio stations, and even the Argentinian embassy in California, but no one could help her. Ultimately, we were able to help her. We put in the work and we found a donor that was willing to donate the thousands of dollars we needed to purchase the drug so we could give it to Asu. Mom saw firsthand that the simple fact that their family was undocumented and uninsured nearly killed her daughter. Life is precious. At our clinic, we fight every day to keep children with their families just one more day. Please help us, fight with us, and give these beautiful children the opportunity to grow up and give back to their community just like I did. Thank you.
Thank you so much, Kat. We'll try again for Miss Annette Logan Parker. Is she available? Well, we'll come back. Let's move on to the next speaker. I think, I can sit here with you and Fabian Oñate for the record. I can sit here with you and talk about my personal circumstances, but that's not merely enough of the problem. I want you to hear, as my colleagues, the personal stories of people who are personally impacted. So we have Rico, and then we'll go to someone in Las Vegas.
Good afternoon, members of the committee. For the record, my name is Rico Ocampo, R-I-C-O space O-C-A-M-P-O. I want to start off by thanking Senator Fabian Oñate for sponsoring this life-changing legislation. I'm here to tell you a personal story of how the current healthcare system in the United States failed my family, particularly my older brother, who we call Carlitos. Our family lives was forever changed in 2006 when Carlitos was rushed to the emergency room with severe abdominal pain. The doctors initially believed that he had kidney stones, but during his surgery, they discovered a tumor in his pancreas. The biopsy results confirmed that it was stage 4 pancreatic cancer, and our world came crashing down. My brother was just 17 years old. When the doctors told Carlitos about his diagnosis, he immediately looked at my parents and he yelled, "No me quiero morir." "No me quiero morir," which translates to, "I don't want to die. I don't want to die." It was a moment that will forever haunt me. Watching my older brother suffer and slowly deteriorate in front of our eyes was one of the most painful experiences of my life. The weeks that followed were some of the most heart-wrenching moments for my family. My father lost his job, and my mother pleaded with the hospital to save her son. We received financial aid due to the hard work of a social worker to pay off our mortgage and utility bills for the first month. But we did not qualify for Medicaid due to our immigration status, even though we were the ideal candidate. The healthcare system failed us, and we were left to bear the burden and emotional burden of Carlitos' illness on our own. Our family watched as Carlitos passed away before he could even make it to his high school graduation. He died as an undocumented person, a tragic reminder of how the country that I call home will gladly receive the fruits of our labor, but deny us our humanity. After my brother's death, we were left with an overwhelming medical debt, totaling over $300,000. To make matters worse, the University Medical Center in Las Vegas, Nevada, put a lien on our house, and they took our house away. Members of the committee, I'm not sure if you've ever been in a situation where you've been stripped of your dignity. But this is one of those moments for me and my family. I am an undocumented person, and I am a human. And I believe that we deserve access to healthcare just like everyone else. We need to change the current healthcare system to provide support and hope to families that have experienced similar situations. I share my family's story not to elicit empathy, but to inspire action. Together, let's support the Nevada Hope Act and create a better Nevada for its residents. A Nevada where the American dream is a reality that is accessible to everyone, regardless of your immigration status. Members of the committee, thank you for taking the time to hear my testimony.
Thank you so much, Rico Fabian Doñate, for the record. Next, I want the committee members to hear from another person that's personally impacted, a nursing student. Samuel, please proceed.
Thank you, Senator, and thank you, members of the committee. For the record, my name is Samuel Cano. I am an undocumented nursing student at the College of Southern Nevada, and I am here today to share my story and to speak out for all those who are facing similar struggles. I have been living in the United States since I was just 4 years old, and Las Vegas, Nevada is the only place I call home. As an undocumented student, I faced many challenges in my life, but I have always been determined to succeed. I have always been passionate about helping out my community, and that is why I decided to pursue a career in nursing. My grandmother, who worked in a small clinic and helped those in need, has inspired me to become a nurse. I knew that healthcare was the path to my success, and I worked hard to make that dream a reality. However, as an undocumented student, I am facing a huge obstacle. I am unable to obtain any kind of health insurance, which is preventing me from getting the hands-on clinical experience that I need to be a successful nurse. This is a major setback for me, and it is preventing me from achieving my goals. It is heartbreaking to know that the only thing standing between me and my dream is something as basic as healthcare. I have worked tirelessly to get to where I am today, and it feels like all my hard work has been for nothing. It is difficult to explain the frustration and sadness that comes with knowing that I am being denied access to something as essential as healthcare simply because of my immigration status. Despite these challenges, I am determined to contribute to this country and to make a positive impact on the lives of those around me. I want to use my skills in education to help those in need and to give back to my community that has given me so much. I urge you all to support me and others like me who are facing similar struggles. We need access to healthcare in order to succeed in our careers and to continue serving our communities. No one should be denied healthcare simply because of their immigration status. Let's work together to make sure that everyone has access to the care they need and deserve. Thank you, members of the committee.
Thank you so much, Rico and Samuel. Vice Chair Wen, I believe there's some technical difficulties with Annette, so we'll try to figure that out. She's having problems being muted and accessing, so if we can come back for her, that'd be appreciated. But in general, I think we're ready to take on the questions. As you know, this is a working bill. It'll go through multiple committees. I would urge, before we ask any questions, I know we're all eager to talk about the financial piece of this legislation. This is the policy committee, so I just want to reiterate that for any of the questions that you may have. And there is a potential that this, with regard to the tax abatement portion of the bill, that it could be referred to the Senate Committee on Revenue and Economic Development, but I'm happy to answer any questions that you may have on this bill.
Thank you, and thank you for that presentation. This was a pretty large bill, obviously, and I think I'll start with some of the questions, if that's okay. And then I will give everyone kind of a round of questions, and we'll come back around through. I know that there are lots of different areas within this bill, and I want to make sure that we're given a sufficient amount of time to fully vet that within our committee. We had talked about, or you had talked about during your presentation, other states that have implemented similar programs. And I noticed the first thing that we looked in that you talked about is how they all started with covering children under 19, but then it clearly looks like they expanded them almost immediately to cover up any of those other gaps. Can you kind of explain more of why that happened and why people weren't covered from the very beginning, like is suggested in your bill?
Sure. Thank you so much, Vice Chair Wen, Fabian Doñate for the record. So, in general, I've had many meetings within the last year or so with folks from throughout different states. And the true reality is it's incredibly difficult to financially project what the outcomes could be for this population. The presentation we heard on uncompensated care is it's hard for us to track how many of these folks live in this state because when they come to the emergency room or to our doctor's office, we don't include what's your citizenship status as part of the form that you have to fill out when you get to the clinic. And that's why it's incredibly difficult for these instances. What we've seen in other states, Oregon's a good example, where it was passed with bipartisan support, and originally they started off with kids and pregnant moms. That's something that's similarly with, as we mentioned in Colorado. And the reason why they did that was because you can't really project how many individuals would qualify or would enroll. You do it in a strategic way where you do certain portions one by one by one. There are certain states that have done different legislation, but California is the one that has expanded it for everyone so far. And most of it comes down to state general funds. The last thing that I would mention to your question, I contemplated personally whether I was going to expand it as what you have in front of you for everyone, or if I wanted it to be, I guess, if you want to use the word strategic, for kids and pregnant moms, etc. But I have family members that are impacted by this bill. How could I turn my back to them? You know, I think they deserve access to care too. That's part of the reason why I got elected. There are people in this building that would be affected by this bill. There are residents of my district. I can't turn my back to them. So that was the reason why I introduced the bill. And I hope that within reiterations throughout this process, we can have a further conversation as to how that looks financially.
And just as a policy in these other states, I know we're not talking about money per se, but obviously it goes hand in hand, and that will be addressed if this makes its way to any of those money committees or revenue committees. But does your bill contemplate, or do these other states, or do they have a way to track the information so they can come back later and say, yes, this saved us a lot of money? Do the hospitals, I know we had a lot of supportive testimony from hospitals, and maybe one of their representatives might be able to come up and answer that question on how they documented, I guess, these savings, for lack of a better term, or the health discrepancies, how they were improved once they started covering people.
Thank you so much, Fabian Doñate, for the record. So that is reflected in, I had the same exact question, which is, let's make sure that we measure that we're doing our work if we do certain capacities to this initiative. You see that with the Medicaid Advisory Group in this legislation. If I think it's the section after the state plan amendment. So in essentially what you would create is, so if the state changes its eligibility, where you can keep the income thresholds, but now you just change the application process as to what requirements are required for you, whether you segment portions of the population or not, at that time frame, if this bill passes to some extent, Medicaid would then have the ability to create a working group of health professionals, FQHCs, MCOs that already have outreach groups. So for two things. One, to continuously monitor the enrollment and aggregation of data points, because we've heard the testimony. What if there's what if there's a stance where there's an increase of enrollment and we're not really sure how to address that? Or the reverse. What if when we enact this legislation, regardless of how many news articles come, people still have a fear of enrolling as part of this Medicaid program? And so the bill covers the same thing which was introduced in Oregon, which is there would be a work group for the facilitation and implementation to track what you mentioned, which is the cost savings, enrollment, etc.
And maybe this is a question young Todd back there might be able to answer, or Mr. Kelly might be able to answer, whether or not the hospitals also have their internal measurements on whether or not they're seeing a decrease in Colorado or Oregon or Washington or any of those other places where some of these hospitals might have other facilities, if they're seeing a decrease in the number of people that are actually coming to the emergency room. And I saw him sneaking up here, so. Yes, I'm putting you on the spot. I could put your picture back up if you'd like.
Well, Todd Sklenberg for the record, great question. I think from a hospital standpoint, we'll have a limited ability. I think you raise a good point of looking at those states being part of a larger national organization who has a presence in Colorado. We could look at that data to see what the impact is. I think as Senator Donate referenced, we'd also need to rely on the MCOs and the federally qualified or other primary care offices to help sort of refine those numbers and the number of new patients being seen who are undocumented, who register for Medicaid, who access primary care. I think that's going to be a key determinant in helping determine the successes.
Senator Stone, do you have a question? No? Yes? Go ahead.
Before I get started, I just want to say a few things that we have a bicameral legislature here. And I have found in my experience in the past that it's really important to collaborate with your colleagues and try to do things as best you can in a bipartisan way. That's why I was successful in my prior state. Senator Donate, I applaud you for wanting to do something to enhance health care for everyone here in the state of Nevada. I only wish that you would include us in your passion to deliver the same. You have a 55-page bill here today that revolutionizes the delivery of health care in this state in following what is hopefully going to be a federal model. I saw this bill for the first time at 9 o'clock this morning. I think my colleagues saw it at 9 o'clock this morning as well. And while we have a Democratic legislature, we have a Republican governor that's made it very clear that he wants to see us working together to try to come up with bipartisan solutions in the best interest of every citizen in this state. So I have to say I'm disappointed that with an issue that I think is so important to you, which is so complementary to your healthcare background, that you've excluded two of us to make up 40% of this committee, where we want to be your partner. We don't want to be your adversary, because we've heard a lot of heart-wrenching stories here today. And I don't want people to think that Republicans are heartless people, that we don't want to deliver health care. We have hospitals that are going to deliver health care to anybody that goes there. We have FQACs that are going to do the same. We all take an oath to want to help and cure people. But we have fundamental issues here in Nevada that we need to address. And I know this is not a financial committee, but I think we've done things in reverse. This should have gone to the financial committee first and find out what the cost is, and then we can back into the policies and make sure we have a deliverable health system. What do I mean? We have a lack of providers throughout this state. Our providers are burned out from COVID. Most physicians, most clinics won't even take Medicaid. Why? Because it's one of the lowest Medicaid fees in the entire country. You can't blame these doctors. They can't even keep the lights on in their offices to take Medicaid. So why aren't we boosting our investment in Medicaid so that we can pay the doctors more and we can pay the hospitals more so we don't have them on the brink of subsidizing and possibly closing their doors, especially in some of the rural counties? So to say that we don't have any struggling hospitals, that's a misnomer. We do have struggling hospitals here, especially in the rural areas, and I'm sure my colleague will be happy to do that. I also have received a number of emails already from people, even though we didn't even have this hearing, It was predicted this was going to show up this morning. I was hoping that it wouldn't, but it did. And frankly, many of the emails are saying, we don't want to continue to subsidize yet more health care for people that are not here in this country legally. Whether we agree with the immigration policies of this country or we don't agree with the immigration policies of this country. But we've learned just today in the prior hearing that if we want to do the right thing, and that is give everybody quality health care, including their hangnails, go into the emergency room if necessary, it's going to be a $5 billion expenditure at a minimum. I'll remind you all, our budget in Nevada isn't that gigantic. We only have a $2 billion surplus this year, and we have a lot of needs, including teachers and public safety, et cetera. You know, I don't want to make this into a partisan event, but, you know, we've had the greatest influx of undocumented immigrants in this country in the past 3 years. And that's okay. If we do, that's fine. But the federal government needs to issue a check so that we can appropriately take care of people. You can have open border policies, that's fine. But President Biden, send us a check. If we have 400,000 undocs that are going to come into Nevada in the next biennium, then give us the cost for 400,000 people to take care of their health care costs so we don't have to depend on our citizens to subsidize and pay for the same at the expense of providing health care to our citizens, which have trouble accessing health care today.
Senator Stone, is there a question about the bill in here?
Yeah, I'm getting to it. I think that the technological advances that you want to do, I think are fantastic. We tried it in California. You'd be surprised how many hospital systems in California still operate with paper charts that don't have electronic charting. It was in the county hospital that I worked for as an elected official. It was a priority to get electronic charting, which saves us money, saves us efficiencies, and actually save mortality because there were less mistakes that were in fact made. So I appreciate what you're trying to do in conformance with the federal model. But Senator, again, I know we can't take costs into consideration, but how, in your mind, do you see us underwriting this program that will allow us to make sure that we don't have people like...
Again, I will remind this committee, it is a policy committee. This will go, if there obviously is a fiscal note that will be attached to it, and so it will go to that fiscal money committee to vet the costs of whether or not we can afford this as a state.
Rico Ocampo, where are you, Mr. Ocampo? I appreciated your testimony, sir, and I'm very sorry for your loss. And I don't want you to think that Republicans are unsympathetic to the needs of you and your family. No one should endure what you've gone through, and not only having to see your loved one pass away due to lack of care, but to have your house taken away from you to pay for the medical bills, to take care of your loved one. That, to me, is appalling. And also Annette Parker, Cure for the Kids. I want to tell you what a wonderful job that you guys do at your clinic. I toured it. We need to get you on the 420B program, right? And listen, a wonderful program like this is fully funded would allow you and it would allow the hospitals to have the resources necessary so we don't turn anybody away. So my challenge for Senator Doñate is how are you going to communicate to people like me the importance of this program so that you can get people like me, if I'm important to the process to you, you're important to the process to me, to engage me as an ally to try to deliver the same.
Thank you so much, Vice Chair Nguyen. Fabian Doñate for the record. You know, Senator Stone, I think part of this conversation is offline. I don't want to take any more time than what the patients deserve to hear, which is the policy aspect of this bill. I will say that there are colleagues that sit on this committee that have seen reiterations of this bill before it came today. I recognize that the nature of introductions are always difficult, but in this state, That's just the way how things operate, and we have deadlines of when we have to pass these bills. But the bill was shared with your leadership, and it was shared with the governor's office, as well as with my leadership and my colleagues, and the healthcare providers that you see in this room today. So I don't want to take this any more longer than we need to, but I think for the portions that you mentioned as to what the cost could be, which is, I will answer it specifically for the sake of these purposes. There are going to be conversations that Medicaid provides as to who is actually covered. And I think it's important to curate for you that Medicaid expansion doesn't cover everyone. There are folks that will probably make too much money for Medicaid, and they could be undocumented, but they won't be a part of this bill. That's what separates us from other proposals that you see in other state legislation. The reason why we did that was because there are folks who, in instances where you see with these kids right here with Cure for the Kids, if you're not able to work, you should still have some level of safety net, because it leads to the level of uncompensated care that we're seeing with regard to our hospital systems, et cetera. And I want to point you back to a slide, which is, I recognize, utilization management, a conversation that we've heard over and over again, right? We already have a shortage of providers, et cetera. That's why my bill covers tax abatements. That's why I've worked to introduce legislation on other pieces of how to expand the pipeline of healthcare, how to stabilize what we're experiencing on the front lines. If you look at this slide from State Outcomes of Colorado, it shows that the direct effect of expanding coverage can lead to better indirect effects of how that actually reduces costs over the long term. I don't think it's easy to say, well, if there's going to be an enrollment of folks, there could be an increased cost of utilization. You heard from Dr. Hardwick today, the utilization already exists. We're already paying for it. What we've seen in other states is this expansion can lead to the decrease of costs when enrollment happens. And I urge you to look at this slide, which is when you enact legislation, whether it's for kids or pregnant moms, what we see in Oregon is they end up going to what we want them to go to, which is primary and specialty care. That is the outcome that we desire for this instance. And I would hope that that is a conversation we can have, and I commit to that.
That's the outcome that I certainly want as well. And I understand, Vice Chair, that we have a 16-week schedule here. And I understand that things are condensed. But 24-hour notice would have been great to at least get through the bill once and maybe come see you with some questions. And I also will point out that California, yes, provides a vast array of services for undocumented immigrants. They're also looking at a $40 billion shortfall this year, and it's going to be interesting to see how they plug that. Thank you.
And I will just remind the people that are in the public, and know that there are quite a few people that are participating in the legislative process for the very first time, probably in their life. I know some people were attending other bill hearings and decided to come in here. We are, as Senator Stone mentioned, we only meet every other year for 120 days. There were, I believe, 110 bills that dropped just yesterday. Unfortunately, they do have to make their way out of these houses by the 14th, or these committees by the 14th of April. So less than a couple of weeks away. So I just, for information for the committee, and this is a very dynamic process, as everyone knows here, and so I know that bill sponsors are continually working on amendments and meeting with you, and I'm sure that Senator Stone, the chair, will meet with you regarding any concerns you have regarding this bill. I will move now next to Senator Titus.
Thank you, Madam Vice Chair. And Senator Donate, I appreciate your passion for your constituents in your district. Recognizing that I am as passionate for my constituents in my districts. And I will tell you that I, as a medical provider, can't get my constituents or my patients in to see doctors because there's not enough of us. So my concern is that, and just so for all of those that presented their stories, I appreciate your sharing your family's stories and your personal stories. I'll share one of mine. My 56-year-old brother-in-law living in Fallon had health insurance, white male, healthy as a horse, died of COVID in 2 months of diagnosis, not getting care. I have a really close friend wake up Christmas Day with pain in his side, went to the ER like everybody does because we can't get them into a provider with insurance. Still no providers could get them in. Goes to the ER. CT scan shows that he has renal cell carcinoma, died 2 months ago. His diagnosis took a month to get into the specialist. So access to care, or lack thereof, is not limited to any person, no matter how much you make, no matter what your insurance is, no matter where you're from, whether you're documented or not. I, as a person who would see anybody walking in my door, couldn't get them referred to a specialist because there's not enough of us. So my concern is, by adding, and I tell people, just because you have insurance doesn't mean you have health care. So my concern is now, as early testimony, potential 95,000 additional folks on the Medicaid roll. Where are you going to, now you're diluting an even more diluted system. So in the long run, it may hurt everyone, the very people you're trying to help. So my question is, how do you solve that access to care when we already don't have enough of us? And so another question would be, when you use states like Oregon and Colorado on what the outcomes were there, what's their ratio of patient to provider? In Nevada, we're the worst, right? We're at the bottom of the list of providers to patients across any states. In Colorado and Oregon, are they at the bottom, or do they already have the access to health care? So I would appreciate my patients not having to go to the ER either, but I can't get them in to see the specialist either, especially GI. I have a person waiting 3 months to get to see a GI specialist. They're fleeing our state. Here in the north, we can't find a gastroenterologist to see people. So my own husband has had multiple appointments canceled because the providers have left to get into a GI consultant. And none of this solves that. As a matter of fact, I see it just adding to the problem. So with all sympathy, and I'll ask all those fiscal questions in the future because I happen to have the advantage of being on the fiscal committee. So I'll address that when that time comes. But this is really about the policy of care to the citizens of Nevada, my constituents, who can't get into care now. And you're asking us to now dilute that so your constituents can get in and see a provider. And it's not something that I, in all good conscience, can see a pathway to access to care.
Thank you so much, Vice Chair Nguyen, Fabian Duñate, for the record. I want to touch on a few of your comments. So let's talk about the dilution, right? If that's difference of opinion, right? I think the utilization of these services already exists. With regard to emergency care services, they're already going to the emergency room. I think all of us can take that into consideration. You came to the same pinpoint that I did, which is, if we have an increase in enrollment, what does that impact our healthcare system? And that's why I have other bills outside of this one to address our provider shortage, how we can engage folks from the health equity side. But the proposals that I have are not merely enough of what this bill does. The reason why I included tax abatements is to cover exactly what you're mentioning. Because oftentimes, as chair of HHS, I have folks that come to me and they are providers that want to move into this state. But we know, because of the external factors outside of this bill, for a number of reasons, where our state has failed, right? Whether it's our Medicaid reimbursement rates, that's always an issue that comes up, which, by the way, is not being solved with this. That's a separate proposal. People always ask me, what else can this state do? I want to move here. I have the employees and the resources because I'm in Arizona or in Utah or whichever. I want to come to Nevada because I believe you guys have gaps that I have, whether it's for mental health services, but I need help. Is there something else that this bill, that your state can do? That's what the tax abatements do. The tax abatements look at healthcare capacity for individuals that want to move to this state, for the equipment that they have to purchase, for wages, et cetera. And And I think that's something that we'll cover if the bill makes it through Senate revenue. But I think when it comes to the dilution of services, we're already seeing the utilization already. You had Dr. Hardwick mention that people are already coming for simple scenarios where they could have gone to primary care. And this is coming from someone that also works in primary care. We can do a better job with coordinating with the companies that want to move here, and we should, because when they look at moving to our state, they always look at two things. What do we do in education? What do we do in healthcare? And if they have to go to Harry Reid to receive the services that they need, Harry Reid International Airport, that's not the way our healthcare system should be ran. And while a lot of them are my constituents for this bill, they're also everyone else's on this committee. Undocumented immigrants live throughout this entire state. It's not just proportionally in mind. Obviously, there's a significant portion that is encompassing. And if you look at my state demographics of my district, about a quarter of the Latinos in my district are uninsured. So the issue could be exacerbated more in the urban areas, but all of us suffer from this system. They're your constituents as well. And I think in general, we want to make sure that they're covered because that's the right thing to do, but it's also fiscally responsible in the long term.
Thank you. Thank you. Next question I have is regarding insurance and the healthcare exchange and applying for insurance. So you mentioned, and I believe your testimony, that many of these folks wouldn't necessarily qualify based on their income. And so are those folks then able to purchase insurance on the exchange? And just an example, we have, because of the uninsured, in my mind, because of Obamacare, which the Affordable Health Care Act, and I'm just going to get on my soapbox and say it was neither affordable nor about care. So what has happened with that is that, as we heard in earlier testimony from the hospitals, the insurance companies are now asking to cover a larger portion for the uninsured. And what happens is those that do have insurance are now paying more for their insurance with their higher deductible. So I have family patients, myself, et cetera, who avoid going to see a doctor because our deductibles are now $10,000. And so our costs are going up high, incredible. So we don't get care because we can't afford it. What is it that prohibits in federal law or state law from a working person that comes to America to work? Because we need the workers. God knows we want people to come here and work. So what prohibits them from buying insurance like the rest of us do on the exchange? And just explain that dynamic.
Thank you so much, Senator Titus. Fabian Doñate for the record. So a lot of this, of course, is predicated based on what federal regulations are. Currently, undocumented immigrants are not eligible to enroll in Medicaid or CHIP or to purchase coverage through the Affordable Care Act marketplaces. Under rules issued by CMS, individuals with deferred action for childhood arrivals, so that's DACA recipients, they're not considered lawfully present for purposes of health coverage eligibility, and they remain ineligible for coverage options. Medicaid payments for emergency services may be on behalf of individuals who are otherwise eligible for Medicaid, but for their immigration status. And of course, I think, so when the Affordable Care Act was passed, it forbid our state from doing that unless if we apply for a waiver. So you can see in one of the exhibits of this bill that Washington just did that. They're the perfect example of applying for a waiver to allow folks to go into the marketplace. The deviation that I would just clearly make is I think that can cover a certain portion of people, those who can afford the plans that are on the exchange. Not everyone will be able to have to do the opportunity to afford that. If you are in the most vulnerable capacity, where, for instances of the kids that we have before us today, oftentimes to take care of a child who has been diagnosed with cancer, who is undocumented, and you are forbidden from Medicaid, there are certain instances where you have to stop working to take care of your kid. And that is where Medicaid coverage comes into play. But that's oftentimes because of how federal legislation works, the states have to put that effort themselves to address this. So we're kind of in this flux, right? We wait for the federal government to take action, but we see this problem persisting over and over again. We still have an obligation to protect the people who live here, who call this place their home. But obviously there are certain nuances that occur when we're looking at federal regulations, and that's the reason why we see the differences with waivers, Section 1332 waivers, et cetera.
So thank you for that clarification. And I would just say that we have a lot of conversation to have afterwards, and I appreciate looking forward to further dialogue. So I'm not going to ask any more questions here today. I think my points have been, I've discussed my points with you. Thank you.
I'm looking around. I'm perfectly willing to go back around for more questions. Do you have any other questions, Senator Stone? No. Anyone else on the committee? Okay. Thank you. I do have one last question. Again, obviously, we've seen some support, and I anticipate there will be more support, not only from providers that provide our healthcare providers, but also our hospitals. Do they see this as we heard that previous just presentation on uncompensated care. Obviously, those are huge numbers that these private hospitals are seeing in their things. Do they see this as a way to, decrease those costs that are being incurred by them already under the current model?
Thank you, Vice Chair Nguyen. I don't want to, Fabian Doñate for the record, I don't want to speak for the Hospital Association or for the hospitals themselves, but I think you can see the value of what you're establishing, because that is why, unless we could actually have Mr. Sandberg if you wanted to speak on that issue.
Todd Sklenberg for the record. Great question. Really want to focus the answer on access to primary care and preventative care. I think that's where we're going to see the savings. The examples that we heard today, having access in a broader network, will reduce costs, because we're going to be able to keep patients out of the hospital and avoid the acute stages of medical needs.
Thank you. Seeing no other questions here, I will go to I first want to point out that we do have a room full of people that are here to testify on this bill. I know we've had a very long presentation. I think it's a very large bill, as it was pointed out. That is pretty substantial policy conversations that we're having. I believe we have people in the overflow room too as well. I see a bunch of people over there, so I want to thank everyone for staying in here. I am going to start with support testimony. I will, just because there are so many people, I want to remind everyone that you can always submit your testimony in writing. You can submit it to the committee secretary here in person, or you can submit it online. The information on the agendas, which are posted right there at the beginning and also online on Nellis, you can get those emails to be able to participate that way. There are a lot of people here, so I will remind you we're going to limit this to 2 minutes. I know that we have a Spanish interpreter that is available if someone needs that person. In my attempts to have some fairness in this, I would ask if it's fine to say me too, or I support, or I oppose. My comments have been submitted in writing, any one of those kind of things, just so we can get through as many people as possible. I'd like to incorporate those people. I am going to start off with 30 minutes in support. I'm going to do 10 here, 10 on the phone lines virtually, and 10 in Las Vegas. And then I will move to opposition, and I will do, again, 30 minutes, 10 here, 10 there, 10 online, and then do neutral. And if time allows, I will go back around for a second round to do support, opposition, and testimony outside. So with that, I will remind every speaker to turn on your microphone, say your name clearly for the record, and begin your testimony.
Thank you, Vice Chair and members of the committee. For the record, my name is Susie Martinez, and I am the Executive Secretary Treasurer of the Nevada State AFL-CIO. And on behalf of over 150,000 members and 120 unions, the Nevada State AFL supports Senate Bill 419, also known as the Nevada's Health Opportunities Planning and Expansion Hope Act, to ensure that every Nevadan has access to high-quality, affordable health care that they need. The Nevada Hope Act will close this gap in care and guarantee that every single worker that keeps our state's economy moving can not only survive, but thrive. The future of our state depends on the health of every single one in our community. By expanding Medicaid to all Nevadans, regardless of immigration or citizenship status, we can ensure that generations to come are happy, healthy, and successful. I'd like to thank Senator Donate and the Nevada Latino Legislative Caucus for bringing up this important issue, and I urge the committee to support Senate Bill 419. Thank you, Chair. Vice Chair.
Good afternoon, Vice Chair Nguyen and members of the committee. My name is Jimmy Lau, and I'm the Vice President of Ferrari Reader Public Affairs, representing the Biotechnology Innovation Organization, speaking specifically in support to the tax abatement and incentives package that are included in the bill. A little bit about BIO. BIO is a trade organization that represents thousands of members across the United States and some other countries, mostly in the smaller and early stages of biotechnology development. We'd like to thank Senator Donate for approaching us for our viewpoints on how to encourage biotech companies to come into Nevada. And we'd like to thank him for including this important piece of his bill, which we feel is going to help bring in additional revenues and additional expertise in our state. Just a fun fact to close this out, approximately 70% of innovative therapies that are developed in biotechnology spaces, particularly in precision medicine, come from small early stage companies. So attracting those into our state is a good thing for Nevada and good thing for the folks who live here. And I'm happy to answer any questions. Thank you.
For the record, my name is Mark Ellis. I'm the president of Communication Workers of America. I represent close to 700 workers at St. Mary's Hospital. We endorse this bill.
My name is Paul Catha, that's spelled C-A-T-H-A, and I represent the Culinary Workers Union Local 226. The Culinary Union supports the goals of SB 19, namely to expand Medicaid to all Nevadans and ensure people have easy access to their own health records, especially underserved populations that can have the most difficulty navigating the health system. Nevadans should be able to quickly and easily access their health information electronically and have the freedom to do what they want with their personal medical information. As the largest organization of immigrants in Nevada, many Culinary Union members reside in mixed status households. When Nevadans are unable to access medical care at an affordable rate simply because of their immigration status, it hurts immigrant workers and it impacts the state. The Culinary Union believes that everyone has a right to health care. When the state excludes Nevadans from Medicaid coverage, the state and our healthcare infrastructure is negatively impacted. Uninsured Nevadans will likely not seek preventative care and increase the burden on local emergency rooms. Culinary Union members have been heavily impacted by the provider shortage in Nevada, and the union supports efforts to bring high-quality, low-cost health care to all Nevadans. We haven't had time to fully review the amendments, but the union plans on having more conversations with the senator, and we support his intent. Thank you.
Good afternoon, members of the committee and chair. For the record, my name is Erika Castro, E-R-I-K-A-C-A-S-T-R-O, and I am the organizing director with the Progressive Leadership Alliance in Nevada, here in support of HOPE Act SB 419. I first would like to thank Senator Donate for bringing this legislation forward to help our state expand healthcare access for all Nevadans, regardless of our immigration status or background. For the first 2 decades of my life, I was one of those uninsured Nevadans that they spoke about earlier, and many of my loved ones continue to be. We are Nevadans like many of you. We also pay taxes for the public services even when we don't have access to them. In 2018, according to the American Council, immigrant-led households paid $3.1 billion in federal taxes and $1.1 billion in state and local taxes. So we're not asking for freebies. We're simply asking for our lives to be cherished with dignity, and we will continue to invest in this country both culturally and financially. I've lived here for the past 30 years, and my parents are getting older. I am constantly worried about how they will get the care they need if my brother and I are not able to pay for the healthcare needs out of pocket. During the pandemic, my biggest worry was having my dad continue to work, risk his life while being diabetic, and having no healthcare coverage. I urge you to support SB 419 to ensure that Nevadans like myself and my family have access to healthcare. Thank you.
Hello, my name is Maria Teresa Lieberman Parraga, MARIA-TERESA LIEBERMANN-PARRAGA, and I'm the Deputy Director of Battleborn Progress. We are in strong support of this bill and deeply thank Senator Donate for bringing it forward. But I'm not just here representing my organization and standing together with the impacted people in this room and providers, but also to represent a little girl who this would have helped. And that little girl is me. before I finally got coverage and citizenship. I'm proud to be part of that influx of immigrants that make Nevada and this country great. And we need this basic coverage. I grew up undocumented, and with that came growing up without access to much, especially medical care and coverage. It took many years of my childhood for my mom to find a job that could provide insurance, at least for herself, and then for me when I finally became a citizen. Shout out to the Culinary Union for that coverage. A kid or anyone should not have to spend years without access to important health care coverage, because I missed out on a lot that I now am suffering from. So please pass this bill.
Good evening, members of the committee. My name is Isabel Bento, and I'm a student at the University of Nevada, Reno, working to get my bachelor's in social work and hoping to get my master's in macro social work. This is my first time being at any legislative hearing, and this is my first time speaking. I do want to address that I'm speaking as a person of privilege, and that privilege being a natural-born citizen. While my father's side is Portuguese and Thai, my mother's side is Irish and have been citizens of the United States of America for generations. Social workers have a code of ethics, which you can find on the NASW website, and these ethics include service, social justice, dignity and worth of a person, importance of human relationships, integrity, and competence. And I believe these codes of ethics should not reside in just social workers, but in all people and all professions. I personally believe that this bill encompasses all the ethics and values I previously mentioned, and is a bill I stand behind. The people who desperately need this bill are your neighbors, friends, family, and people in this very room, including myself, who has been on government assistance all my life due to living in low income and just above the poverty line. And my family has been uninsurance for all my life. Each parent working 2 or more jobs, working until they get disabilities at the ripe age of 40, and avoiding the emergency room at all costs. My mom avoided going to the emergency room when she had extreme abdominal pain, and it wasn't until she was pushed by her boss to go to the ER, where she found out her appendix was about to explode, and if she came any later, she would have died. My mom's story is not unique, and fortunately, she was able to get the care she needed, but this is not the case for thousands of people, especially for those who are unrepresented, for those who are marginalized, and for those who are the most vulnerable. I encourage people to think back on the code of ethics when thinking about these people in this community, and when thinking about people like me, my mom, and all the undocumented people of this country. This bill will save the lives of all ethnicities and identities. Thank you for your time.
And I'm going to do these last 2 here, and then I'm going to go to Las Vegas. Go ahead.
Good afternoon, Chair and members of the committee. For the record, my name is Jose Macias, and I've been a longtime community leader working with the immigrant community here in Nevada. Today, I'm here to urge you to support SB 419, the HOPE Act. After the pandemic, we all learned the importance of being healthy and making sure that not just our families are healthy, but our entire communities are. If one of us gets sick, it's important to make sure we take the right steps to ensure not everyone else gets sick too. This bill will allow our state to expand healthcare for everyone. In times when silent killers like diabetes and high blood pressure are at an all-time high in our communities, we have to make sure people have access to preventive care and not wait until it's about life or death. Personally, I lived through this with my mother, who never had access to care or even crossed her mind that healthcare was something she would be able to get. My mom was a hard worker, but unfortunately, because she didn't have healthcare, she would rather go to work feeling sick than even get checked up. Sadly, when she finally went and checked into a hospital, it was too late for her. It's now been 9 years since she passed away from a stroke. It's been 9 years, and many families in Nevada are still in the same shoes as my mom and my family. 9 years later, and once again this Thursday, I'll be putting to rest my Aunt Rosa, who passed away last week from diabetes. Today, at this very moment in Las Vegas, my dad is at home figuring out if he can make it to his chemotherapy appointment for cancer, because he doesn't know if we have enough cash to afford it, since we pay hundreds of dollars out of our pockets to make sure he gets his healthcare needs met. No one should be worried about having access to chemo, access to a checkup, or just access to being healthy and able to thrive in dignity. Life is not about blue or red, it's about human rights. Rosa Rivera is my aunt's name. I ask you that you don't forget about her when voting for this bill. Tomasa Macias is my mom's name. I urge you to not forget about her when voting for this bill. Martin Macias is my dad's name, and he still has life, so please don't forget about him when voting for this bill. So many Nevadans are still counting on you to
I'm
do
sorry, I'm going to
humane
need you to
things
wrap up your testimony.
and pass the HOPE Act, so please support SB 419. Thank you.
We'll go to one more here in Carson City.
Buenas tardes a todos. Mi nombre es Guadalupe Guzmán. Soy sobreviviente del CEPSTRO del Banda Levey de 2017.
Can I have you stop for 1 second, and then I will have someone that
Desde
can
entonces
interpret?
soy miembro del... ¿Mande?
Sí, le puedo pedir que
Do we have an interpreter that's on Zoom?
yes, just as
I'm going to ask her
on,
to speak slowly and allow you to interpret if that works out. And I'm going to ask you to start all over. Okay, go ahead and begin.
Hola a todos.
puede
Buenas
iniciar.
tardes. Mi nombre es Guadalupe Guzmán. Soy sobreviviente del CEPSTRO del Banda Levey del 2017. Desde entonces soy miembro de Black Pro Nevada. Vengo aquí a dar mi apoyo. El SB
And can you stop so he can interpret for us?
414. Después.
disculpe, señora González. Disculpe, señora González, déjeme, si pudiera entonces nomás dar una oración a la vez, así puedo asegurarme de interpretar precisamente lo que usted está diciendo. Muy bien. Good afternoon, everyone. My name is Guadalupe González.
Guzmán.
Guzmán. ¿Y usted es sobreviviente de qué mencionó?
Del CEPSTRO del Mandalay Bay del 2017, del concierto del Mandalay Bay de la música country.
I am a survivor of the Mandolin Bay, from the Mandolin Bay attack of 2017.
Ya. ¿Ya?
Adelante.
Después del CEPSTRO, les puedo decir que siento secuelas de estrés postraumático. Para mí fue un hecho que me cambió la vida totalmente. Me ha generado mucho estrés. Tengo problemas.
So I can honestly say that I still have secondary effects from having experienced post-traumatic stress from that trauma. It has changed my life. Adelante.
Tengo problemas de presión alta. A veces me despierto de noche y sin reconocer dónde estoy. Asustada, como sabemos. El estrés los afecta en muchas formas y en mi caso terminó aportando a que sea diagnosticado con diabetes. Como todos sabemos.
So I suffer from high blood pressure. I wake up at night not knowing where I'm at. The stress has really affected me in many ways, and also I have diabetes.
Como todos sabemos,
Adelante.
el 2020 nos llevó a vivir una pandemia terrible a la cual yo asistí al hospital. Significó perder mi trabajo como parte de un equipo que planificaba eventos. Con perdí todos mis beneficios. Al día de hoy yo no tengo seguro. Llevo 2 meses sin mi medicamento para el diabetes.
So, as we all know, 2020 affected us with the pandemic that I ended up in the hospital, and I lost my job in planning events, and I lost all my benefits. I have no insurance, and I have 2 months without my diabetes medication.
Yo tengo hijos, pero ni ellos ni yo podemos costear los medicamentos. Si yo no consigo los medicamentos necesarios, esta situación solo va a empeorar. Todos tenemos a un familiar o amigo conocido que tiene diabetes. Las consecuencias son terribles. En caso que no se mantenga controlada, yo quiero tener una vejez digna en la que pueda mantener mis piernas y mi vista y no ser una carga para el gobierno o mi familia.
So I have sons, and even with my sons, we cannot pay the medication. And we all have people that we know that if they don't have their medications, the situation only gets worse. With even if I cannot receive my medications, my diabetes is going to get worse, and I will not be able to control the diabetes. I want to be able to live a long life and a dignified life with my legs and my eyesight, where I'm not going to be a burden to my family or the government.
Yo he trabajado y contribuido a este país por 22 años, pagando mis impuestos como cualquier ciudadano. Merecemos poder tener algo tan básico como es atención, medicamentos para poder mantener una vida digna. Por eso es que les pido que me apoyen a la CB 114, apoyen a que todos trabajemos por Nevada y podamos envejecer tranquilos y sanos. Thank you.
I've worked for this country I worked in this country for 22 years, and I've paid my taxes just as a citizen. We all deserve the basic medical attention, and I want to live a dignified life. That's why I ask for you to vote yes on 114. That way I can continue to work and have a dignified life. Thank you.
Thank you. And right now, I am going to ask anyone that wants to testify in support of Senate Bill 419 in Las Vegas to kind of fill in those chairs. I don't know if anyone's moving. I see people walking around, but I don't know if they are. But if you can just kind of keep them full, again, I would remind everyone that you can say, yes, me too. I support this. And again, please limit your testimony to 2 minutes and go ahead and begin when ready.
Good afternoon, everyone. My name is Fabio Diaz Ortega, certified medical interpreter and patient experience associate at Cure for the Kids Foundation. Let me tell you about Francisco. At the age of 5, he would happily run, jump, and play until one day he couldn't. He complained to his mother, Beatriz, that his legs were hurting. The very next day, he was unable to walk. Thinking nothing of it, Beatriz took her son to the pediatrician to hopefully resolve this issue. It wasn't a quick fix. It was acute lymphoblastic leukemia. When it all started, Beatriz didn't know where to begin, what his future will look like. Will he die? Will he live? And will we get the help that he needs? Being undocumented, Beatriz found the last question to be a penumbra of pain as she watched her son relieve countless spinal taps and chemotherapy. Often, she'd be in the exam room listening to the oncologist prescribe medications she was sure she could not afford, regardless of the discount prescription cards and copay programs offered by drug manufacturers. Hospital stays brought on their own set of challenges. Beatriz remembers vividly creating payment plan after payment plan to provide her son with the care he truly deserved, care he could only find in the battle-born state but had limited access to due to immigratory status. So we ask you, on behalf of all the undocumented children, on behalf of Cure for the Kids Foundation, that the state of Nevada pass the HOPE Act for all warriors. And if home really means Nevada, let's take care of our families.
My name is Maria Farmer. I'm a patient financial counselor at Cure for the Kids Foundation. Our children not only need chemotherapy infusions, they need also other specialty care such as physical therapy, dental care, things that they just do not get because of their immigration status. And we try to treat the whole child, not just, a certain part. We try to treat the whole child. So on behalf of Cure for the Kids, we are asking to please pass Senate Bill 419, and let's get the children and our future children of Nevada the care that they need. All over the state, in Las Vegas, Reno, wherever they live, they need the care. They have sometimes no choice where they wind up, and they just wind up here with us, and we try and take care of them, and we try and provide all the services that we can for them, but we really need your help. And if we can get this bill passed, that'd be great. Thank you so much.
Hello, members of the committee. My name is Paola Davila. It's spelled Paola-Davila, and I work in early intervention. I'm a development specialist in the state of Nevada. I have lived in Las Vegas for 18 years. I'm a current resident of Assembly District 11 and a Senate District 2, here in the support of Bill SB 419. Hola, miembros de la comité. Mi nombre es Paola Dávila y trabajo en la intervención temprana. Soy especialista en desarrollo en el estado de Nevada. He vivido en Las Vegas durante 18 años. Soy residente actual del Distrito 11 en la Asamblea y del Distrito 2 del Senado. Aquí en apoyo proyecto de la ley SB 419. I am an immigrant and I have been lucky to graduate from UNLV. I am fortunate to work in early intervention and provide services and support for children with developmental delays and disability, as well as their families. A lot of these families are uninsured immigrants and struggle to receive the help and care they deserve. Soy inmigrante y he tenido la suerte de graduarme de la Universidad de Nevada. Tengo la suerte de trabajar en intervención temprana y brindar mis servicios y apoyo a los niños con retrasos en el desarrollo y discapacidades, así como igual a sus familias. Muchas de estas familias son inmigrantes sin seguro y luchan por recibir la ayuda y la atención que merecen. While Part C and Part B are provided by the state, children in early intervention benefit exponentially from private therapy since the first 3 years of their lives are the most important in development. In addition, some require therapy throughout their lives. Private therapy, as we know, requires insurance, which creates a barrier that impacts children's development and quality of their life. Mientras que parte C y parte B son proporcionadas por el Estado, los niños en los programas de intervención temprana se benefician exponencialmente de la terapia privada, ya que los primeros 3 años de su vida son los más importantes. Además, algunos requieren terapia durante toda su vida. La terapia privada, como sabemos, requiere un seguro que crea una barrera que impacta el desarrollo y la calidad de vida de los niños. Many of the immigrant families I work with
I'm going to
cannot
ask you
afford
to go
private
ahead and
therapy.
wrap up, and if you have some further testimony, please submit it in writing.
Yours and mine and our families are hardworking Nevadas that want the best for our communities. Children of Nevada and their families deserve to have access to health care regardless of their status. I urge you to support SB 419 and change the life of immigrant families and their children, especially those with development delays and
I'm going to have to go
disabilities.
on to our next
Thank you.
testimony. Thank you for your testimony. If we can fill in those chairs, go ahead and begin when you're ready.
My name is Alyssa Cooley, A-L-I-S-S-A-C-O-O-L-E-Y, and I'm the managing attorney of the UNLV Immigration Clinic at the William S. Boyd School of Law. I'm also a member of the Nevada Immigrant Coalition. For clarity, I'm not speaking on behalf of UNLV or NSHE today, but I do want to express the importance of SB 419 for our clients and other undocumented folks. Imagine an asylum seeker whose government persecuted and tortured him, who fled his native land, leaving everything and everyone he has ever known behind to save his life. Imagine that he presented himself to the U.S. and lawfully sought protection through asylum. Now imagine that due to the ever-increasing backlogs in immigration court, not to mention the delays caused by a global pandemic, he will have to wait years and years for the adjudication of his asylum claim. If eventually granted, he will receive refugee benefits, which will include Medicaid. But while he waits, contrary to popular belief, he will not receive any refugee or other public benefits. This asylum seeker who fled horrific torture in his home country and who is suffering the physical and mental effects of state-sponsored abuse has to wait years before he can receive medical coverage to treat those ailments. Meanwhile, his conditions are worsening to the point of requiring emergency medical care. Without access to medical coverage, he and other undocumented folks in our community are left to suffer from treatable conditions conditions that could have been prevented with timely medical attention. Currently, all persons in Nevada are eligible for emergency Medicaid, regardless of status, and that treatment is expensive. I hope we can all agree that preventative care is more cost-effective than treating serious or chronic conditions in the ER. I ask the legislature to vote in favor of SB 419, not just for our clients and other undocumented folks in the community, but for the benefit of Nevada as a whole. Thank you so much.
For the record, my name is Amber Williams McGee, and I am a healthcare worker at Cure for the Kids Foundation. I am here to clearly state Cure for the Kids Foundation's strong support of SB 419. In our business, we understand the massive need for this type of reform as we see so many cases of undocumented children not receiving the life-saving care that should be the most basic of human rights. All of the organizations we heard from today take on the burden of this care, which should be handled by the state. C4K handles the majority of care for children with rare diseases, but it is certainly not an option for the undocumented population as a whole. Daily, we see firsthand the damage of what not being insured does to our hardworking undocumented families who are just left alone to suffer. I want to thank Senator Donate for bringing this important initiative to the table for discussion. Our state can do better. Our people deserve better. Let's change our state's reputation. Let's start to take steps to put Nevada on the map regarding healthcare for everyone's sake. Once again, I truly believe the HOPE Act will inspire just that, bringing hope to thousands who have been living in fear. Thank you so much.
And I'm going to take, is there anyone else to testify in Las Vegas in support? I can take one more down there in Las Vegas. Seeing none. Broadcast services, can we go to the line?
Thank you, Chair. If you are in need of a Spanish to English translation and would like to testify in support of SB 419, please press *9 to take your place in the queue.
Hola, si necesita interpretación en cuanto a esta propuesta de CSB 419, favor de oprimir estrella 9 en su teléfono para poder colocarlo en línea para poder comentar.
If you would like to testify in support of SB 419 and do not require translation, please press *9 to take your place in the queue.
Good evening. My name is Cyrus, C-Y-R-U-S. The reason I support this bill because today I identify myself as an undocumented immigrant. And I'm certainly hoping that this health insurance is better than what my employer gives me. And please expand language services to Persians while you can. And also, can you tax the casinos, not the middle-class people? And let's extend towards Medicare for all, because I think everybody should be covered. Yield my time.
We can go to our next caller.
Good evening. This is Maya Holmes on behalf of the Culinary Health Fund. We want to thank Senator Donate for bringing the HOPE Act forward. We're in discussions with the senator on a few aspects of the bill that we're trying to understand better, but we absolutely support efforts to ensure medical record interoperability and patient access to their medical records so they and their providers can seamlessly access, retrieve, and send the records where they need to and when they need to. We agree with the intent of the legislation to align the state with national standards for interoperability so we can move away from siloed information that is not meeting the goals of health information interoperability within the state or nationally. Moreover, and fundamentally, we also support the Medicaid expansion to all residents of Nevada, regardless of their citizenship status, which will strengthen our healthcare system as a whole, improve the overall health of residents in our state, and ensure no member of our community is left behind and cannot receive the health care they and their family need. Thank you.
We can go to our next caller.
Good evening, Vice Chair Wynn and members of the committee. This is Holly Wellborn, Executive Director of the Children's Advocacy Alliance, testifying in support of SB 419. This is crucial legislation for expanding and encouraging access to care for Nevada's most vulnerable community members. I have a bunch of stats here, but I'll just focus on a couple. 42% of eligible foreign-born children in the U.S. are ineligible for Medicaid or CHIP benefits. And children who are eligible often do not get care because their ineligible parents are too afraid to access it. Furthermore, Nevada has one of the lowest participation rates for eligible children. We must change course. This is visionary legislation. We applaud the senator for his leadership and encourage your support.
Chair, there are no additional callers for support at this time.
Thank you. At this time, I'm going to come back to Carson City, and it looks like, hold on one second. I'm going to now begin opposition testimony. Again, I'd ask people to come up to the front and fill in those chairs. Again, remind everyone that please limit your testimony to 2 minutes, and please state your name clearly for the record and begin when you are ready. And again, I will allow another 30 minutes for this. That's fine.
It is of my opinion, this is Casey Rogers. It is of my opinion that I actually feel this is more of like a power grab on the medical digital side of things that I don't agree with. I think there could be nefarious reasons for it, for digital tracking, which leads to digital dollars, which leads to digital humans, actually, where you can turn on and off certain aspects of people's lives. I just think that this needs a little bit more digging into. And then I would echo, because I'm going to keep this short, exactly what Senator Stone brought up, because everything he says has weight, carries immense weight. As much as I feel that people deserve medical, I also feel that taking from some and giving to others is not necessarily what this country should be about. I feel like if I want to go into another country and do the same thing, would that be accepted amongst their citizens? It's something to consider. Thank you.
Good evening, Madam Chair, members of the committee. My name is Janine Hansen. I'm the state president of Nevada Families for Freedom. We have several concerns about this bill. One is the issue of the connectivity and the networks. There's no guarantee of privacy or safety or security in government networks. This is supposed to be a state network. Well, it's going to be connected to a federal network. Will it also be connected to the Global World Health Organization? We have considerable concerns for privacy and health freedom. In Nevada, when we had the vaccine mandates, we could show how some of these networks might be abused. People who refused to get the vax, lost their jobs, were retaliated against, were denied health care, even life-saving health care. And so if your name is in a government database and they know what your health care decisions are, you could be retaliated against and lose your opportunity for health care. So we're concerned about that with this network that's going to be in this particular bill. We're also concerned about the cost. Paying for illegal aliens through the insurance is bad enough, but using tax dollars is far more expensive and less efficient and creates more bureaucracy and more government jobs. We simply can't afford it. According to the Institute for Policy Innovation in the United States, the total U.S. tax burden, including federal, state, and local taxes and hidden taxes, is equal to 56% of annual personal consumption spending. 56% is more than a person spends on housing, food, health care, transportation, education, and recreation. How can people possibly take care of themselves and our families when government takes 56% of our income. Government taxation is a major cause of family financial distress. No wonder more and more people are slipping into poverty. We encourage you to reconsider this bill and defeat it. Thank you.
Madam Chair and Committee, my name is Lynn Chapman, and I'm the State Treasurer of the Independent American Party. $5 billion startup money, and that's a lot of money, especially for people like me who are on a fixed income. We have bills before our state legislature for affordable housing, asking for higher property taxes. Schools want more money, higher taxes. Now medical care for everyone who comes here. We, the taxpayers, can't afford it. We just don't have enough money. So please vote no on SB 419. Thank you.
Good evening, Senators. Joy Trushinsky, Trushenski, for the record. First, I want everybody to know I support legal immigration. However, I oppose SB 419, which gives taxpayer-funded Medicaid insurance to illegal aliens. Currently, citizens are suffering due to high taxes for everything, due to government-caused inflation. They cannot afford to give illegal aliens Medicaid along with welfare payments, housing, food, education, and so much more. Giving free stuff will only encourage more illegals coming over our unsecured borders. This is a national security issue as people are not being vetted. I also am strongly opposed to a centralized government healthcare database of all health records, which includes whether or not you took the untested, dangerous COVID-19 vaccines. This bit of the bill is, in my opinion, communistic and, like Big Brother, is going against freedom and personal privacy. Please vote no on AB 419, giving non-American citizens taxpayer-funded medical insurance along with everything else. This is totally unsustainable. Thank you for your time.
Good evening, Madam Chair and Senators. Susan Rue, for the record. I'm deeply concerned that the Nevadans cannot afford this legislation. Many people who are actual citizens of our state can't afford their premiums due to Obamacare. They can't afford their deductibles because the insurance companies must charge more to cover the Medicare and Medicaid cost. The state of Washington and the state of California have financial difficulties because of all their social programs. Unfortunately, life is not fair. I tell that to my daughter all the time. I know people, citizens, that make daily decisions about taking their medications. We can't afford this bill, and I'm asking you please to vote no for Senate Bill 419. Thank you.
Good afternoon. My name is Julie Burke, and I oppose this bill. And I think that there may be some misconception about who actually has health care struggles. I at one time was pregnant and needed obviously health care and was turned down by my first obstetrician, and because I didn't have health care, and finally I had another obstetrician, and she required that I pay up front before she would give me care. I also had a special needs granddaughter who needed a pediatrician, and I called every pediatrician literally in Reno and Sparks and Carson City, and finally found one in Carson City who would take Medicaid, but then he dropped her. I have insurance, but during Obamacare, I will tell you that it went up so sky high as a single parent. It did create financial difficulties for me. I think given the situation at the border currently, it is not a good time to pass this bill. I believe the legal citizens in Nevada need to be a priority, and this just sounds extremely costly at this moment. And lastly, I just want to say that decisions, and I'm not being mean, but as I always told my kids, decisions have consequences. And making a decision to move to Nevada doesn't necessarily mean one deserves something. As I said, decisions have consequences. And finally, I also do not agree with the network aspect of the bill. So I thank you and I encourage your opposition to this bill. Thank you very much.
Chairman and members, thank you for the chance to testify. I agree with especially the mechanical
I'm sorry, could you say your name for the
I'm
record?
sorry.
That's okay, that's okay. We all get nervous at the microphone.
I goof up every time. I'm sorry. Barbara Jones, for the record. I'm really sorry. I go back thinking of my own past, working all my life, and from 84 to when I retired, I had no insurance, working, my whole life, not on welfare. And so actually, for those that are sick and I sympathize with, that need help. But all of my issues went to Jesus, to be honest. And I got healed of back trouble. I got healed of carpal tendon, a cancer on my breast. And with Medicare, I guess I didn't have to rely on him as much, and I did have 2 hospital visits because somebody was paying the bill. But I had to pay my own bills or, not do it. And I think that if we called on him, for those here that are sick, I sympathize. It's not fun. But the mechanical aspect is so dangerous. We have bills now, and the children that were put in the database, the vendor sold it to China, so your kid's information is in China and you don't even know what they have on you. And it's the same thing with your health care, and it's the same thing with voting. So thank you. Please vote against this bill. Thank you for your time.
Thank you for your testimony. At this time, I don't see anyone in Las Vegas, but I am going to ask if anyone is there to testify in opposition to this bill. If you could come up to the table right now. I see some movement, but I don't know if it's moving up to the table. Yes, I see someone. I'll just remind you to please state your name for the record and begin your testimony. Make sure you press that microphone. And again, limit your testimony to 2 minutes, please.
Well, first of all, I'd like to thank you all for addressing a medical issue. We have medical issues in Nevada, and they need to be addressed.
And
but
I'm
I
sorry,
don't
can
think
you
that this
state your
bill
name
is
for the
going-
record?
Oh, goodness gracious, did I forget? Susan Prophet, I'm the Vice President of the Nevada Republican Club, and I'm going to speak for myself today because I've heard a lot of emotion on the other side. And in this particular case, I can speak from experience. It has devastated my family, devastated to the point where we almost left the state. We don't have enough medical care for the people that are here, but I really do welcome the new people that are moving here. I mean, I really do. We need immigration, but we need it to be done in a logical manner. And I do believe that we have a lot of issues that can be addressed if you will take the time to look at all the aspects that have added to the situation instead of coming up with this particular bill, because this one creates a lot more issues for many, many people. And so thank you for addressing this, and thank you very much, Senator Stone and Titus, for your astute understanding of this hot mess and this bill will create. And And so I oppose SB 419 because it doesn't resolve the problem. It magnifies the mistakes of our government when they forced Obamacare on Americans, and they didn't plan properly and they didn't implement it properly. And so it has created a nightmare for me, my family, and many others. Socialized medicine sound like a wonderful, wonderful thing, but I'm telling you, the road to hell is, really paved with good intentions. And I know you have good intentions, so I don't mean to insult anyone today. But it's not helping our neighbors, our new neighbors either. Nobody is going to benefit unless we change a few outdated laws and fix the problems created by a hastily planned and poor executed medical system. And
I'm sorry, can
our
I get
current
you,
healthcare-
you're at a little over 2 minutes, so if I can have you wrap up, that would be great. And please submit your testimony in writing if you'd like.
Okay, may I please finish this paragraph?
Yes.
I have not had 2 minutes. Okay, I am a handicapped senior citizen on a fixed income. I paid $500 a month. It rose to $24,000 a year by the time I was old enough to get on Medicare, which I paid for all my life. When my husband got lung cancer, he was forced to wait a year in Nevada for surgery, and he was spitting up blood the entire time. After having a third of his lung removed, the cancer returned. So Senator Titus and Senator Stone, I really appreciate you fighting for us right now. My husband is going to die. And I have already lost my daughter to the fentanyl and our son to a sudden death syndrome that's going around now. So I really am a mad mother right now. And I am mad with our government because they are not properly planning before they make these laws and put them into place.
Okay, at this
And
point,
so
I'm going to
I
have
beg
to
you
move on
not
to the
pass
next
this.
person, but thank you.
Don't pass it, please. Thank you, Stone.
Do we have any other people to testify in opposition in Las Vegas? Seeing none of the table broadcast services, can we go to the telephone lines?
Thank you, Chair. If you are in need of a Spanish to English translation and would like to testify in opposition to SB 419, please press *9 to join the queue.
Hola, si usted está necesitando interpretación del español al inglés y le gustaría dar su testimonio en contra de SB 419, favor de oprimir estrella 9 para poder colocarlo en línea para comentar.
If you would like to testify in opposition to SB 419, please press *9 to take your place in the queue.
Hi, my name is Lisa Partee. Last name spelled T as in Paul, A-R-T as in Tom, E-E. These stories of hardship are heartbreaking, but people who are here legally right now cannot get the health care that they need, and they have insurance. Many of these stories would not have happened if you just come here legally. To give Medicaid to the folks here illegally flies in the face of all Nevadans. We've been taxed to death to pay for program after program for people who don't contribute, and for those who are here against the laws of our land, and for this body to reward this lawlessness by making me and my family to pay their ways an absolute insult. And the HIPAA law provides protection for all of our health information to remain private. For you to want to volunteer to put us on a United States federal government database flies in the face of the Constitution. You're taking away our autonomy and our privacy. You swore an oath to protect our Constitution and from enemies, foreign and domestic, yet you want to give a handout to those who flaunt our laws. Are they too subjected to these socialist treatments? I'm all for people coming to this great country, but come in the front door. Contribute to society and feel pride in your ability to do so like the rest of us. This is a socialist bill. It's unconstitutional. It's anti-American and unsustainable. And I have to say, I really resent the fact that there's people wearing signs, holding signs and shirts in the camera view, whereas there was a bill last week on abortion that was not allowed for that to happen. This one-sidedness really needs to stop within our legislature. Thank you.
We can go to the next caller.
Good evening. Bob Russo for the record. I oppose Senate Bill 419, which would provide taxpayer-funded Medicaid for individuals residing in Nevada illegally. As I've said before, I have no issue with anyone who wishes to come to America, provided they adhere to our immigration laws. Unfortunately, this bill would encourage more people to enter our state illegally to receive health care benefits. Plus, given the shortage of doctors in the state, it would put greater strain on our health care system and on the insurance companies. Additionally, this bill could end up being a huge financial burden to our state. Nevadans are already experiencing the strain of rising inflation, which is unlikely to reverse course for the foreseeable future. The Nevada Globe stated in an October 14, 2022 article that inflation in Nevada has reached 16% and hitting Nevada households the hardest. Rising prices are costing Nevada households an additional $867 a month, or $10,402 a year since January of 2021. And the Daily Mail reported that in 2021, Americans spent more on combined taxes than they did on food, clothing, and health care. Lastly, I have concerns that this bill would contribute to a centralized government health database that will violate the privacy of Nevadans and put bureaucrats between doctors and patients. Would this not violate the standard of confidentiality that exists between them? Could we see social credit scores to receive goods and services? It's for these reasons that I ask you to please oppose Senate Bill 419. And I want to thank Senators Titus and Stone for their excellent interactions on this bill and the great testimony and information that they have provided. Thanks again.
And at this time, I am going to close this first round of opposition testimony. And just for the record, I've looked around and I don't see any signs. I know there was a caller, but I want to make it very clear that I haven't seen any signs. I know that Senator Titus would have pointed it out immediately if there were, and she has also indicated, she's nodding here, that we did not see any signs. So I just want to make that very clear that I did not see any signage posted here in this room. At this time, I will go to testimony in neutral. So if you have neutral testimony, please come up to the table. Seeing no one in neutral, I will go to Las Vegas. If there's anyone that would like to testify in neutral, please come to the table. I don't see anyone in Las Vegas coming to the table in neutral. So at this time, Broadcast Services, is there anyone in neutral testimony?
Thank you, Chair. If you are in need of a Spanish to English translation and would like to testify in neutral for SB 419, please press *9 to join the queue.
Si usted necesita interpretación para dar testificación de SB 419, por favor, estrella 9, y si está por teléfono, para ponerse en la lista, o levantar su mano electrónica si está por la aplicación Zoom.
If you would like to testify in neutral for SB 419, please press *9 to take your place in the queue.
Si usted desea testificar bajo neutral para SB 419, estrella 9 para ponerse en la línea. Oprima estrella 9.
Chair, there are no callers choosing to testify at this time.
Thank you. So we will begin support testimony again. Again, I will remind everyone, if there's anyone else in overflow, I'd ask you to come into the main committee room. And if we can just fill in those seats. If you do have something in writing, please feel free to submit that. And if you do need a Spanish interpreter, if you can just kind of wave at me and I can make sure I can get that person on our line. Go ahead and begin when you're ready.
Buenas tardes, mi nombre es Emperatriz Álvarez.
One second.
Yes, good afternoon. My name is Beatriz Alvarez.
Emperatriz.
Imperatriz. IMPERAT. RIZE.
Z with a EMPERATRIZ. Emperatriz. Okay. Buenas tardes a todos los presentantes y presentes hoy. Mi nombre es Emperatriz Álvarez y soy miembro de Make the Road Nevada.
You can go ahead and interpret.
Good afternoon, everyone. I'm dice que es parte de ¿qué grupo?
Make the Road Nevada.
Make the Road Nevada.
Estoy aquí para mostrar mi apoyo, conocida como Home Act, la ley SB 419.
So I'm here in favor of Home Act SB 419.
Porque me afecta personalmente.
This affects me personally.
Soy una persona que en el 2014 me diagnosticaron con células cancerosas de pelvis.
So I'm a person that's been affected. In 2014, I was diagnosed with cellular cancer in the pelvis area.
Cuando me detectaron esas células cancerígenas en la zona pélvica, un tipo de cáncer que me dijeron que era muy silencioso y mataba muy silenciosamente mi persona también si no hubiera sido descubierto a tiempo.
I was told that when this cellular cancer was discovered in my pelvis area, that it was a very silent killer, and if it hadn't been discovered.
Fue por un chequeo que fue gratuitamente y yo fui y me diagnosticaron ahí. Entonces dije, ¿qué sigue? Me desesperé y empecé a buscar ayuda o un tratamiento y fue muy difícil encontrar un lugar donde me dieran un diagnóstico más claro.
So it was very, where it was diagnosed or they found it was in a free checkup that I went to. And when they discovered it, I asked, okay, what's next? And they, as far as treatment goes, so it was very difficult for me to find any type of treatment or find any other treatment that would give me a more clear diagnostic.
Soy mamá de 5 niños, 2 con autismo, y lo primero que cuando me diagnosticaron me dijeron, qué bueno que viniste, porque si no hubieras llegado a tiempo, ese cáncer te hubiera matado silenciosamente y hubieras llegado quizás en una etapa terminal.
And they told me I'm a mom of 5 kids and 2 of my children have autism. And they said, you know, you caught this on time because if you wouldn't, this is the silent killer. And you would have, ended up here at a very terminal state.
Me pasé por biopsias, pasé por varias cosas. Cada 6 meses esos chequeos, cada 6 meses esos chequeos, muy dolorosos.
I went through several biopsies and several checkups every 6 months. It was a checkup every 6 months was a checkup, and they were very painful.
Hasta que un día el doctor me dijo, necesitas un tratamiento más, porque esas células pueden regarse adentro de tus órganos.
So until the doctor told me that I needed I needed a certain treatment, because he said those cancerous, there's cells that are cancerous can spread to your internal organs.
Me dijeron que necesitaba un tratamiento, que era un congelamiento y tenía un costo. Ese costo era caro para mí, puesto que no lo hice los primeros años hasta que logré el dinero, hice el primer tratamiento, cash.
So that I was told I needed a certain treatment, like a freezing type treatment, and the costs were just too high for me, that I didn't do them the first years until I was able to pay in cash for this treatment.
Yo trabajo, hago taxes, pero aún así cuando me diagnosticaron era una mamá soltera y estaba en pago el tratamiento o pago mi renta o compro comida o pago mi luz. Esa era mi lucha entre mi tratamiento y lo que estaba pasando en ese momento.
So I work, I do taxes, but I was a single mom at that time, and it was either pay my rent, pay food, pay my light, or pay the treatment. And this was the situation I was in at that time.
Entonces entré en el primer tratamiento, pero no lo pude terminar por el costo.
So I went into my first treatment and I wasn't able to finish because of the cost.
Quisiera saber si existieran lugares donde diagnostican a las personas, ya que yo no sé si en un momento puede crecer, Dios no quiere ese cáncer, a dónde voy a ir, quién me va a ayudar, puesto que yo siento que también tengo derecho porque también pago mis taxes.
So I'd like to know if there's a place where I can continue, if there's another diagnostic, if it's gonna spread, if it has spread, where do I go to receive this help? Because I also pay my taxes, and I also feel that I should receive this medical treatment.
Pero siento que no he sido escuchada y quisiera que nuestras historias se escucharan, porque es desesperante saber que si mis hijos un día se quedarán sin mí, ya que ellos son chicos.
So I feel like I have not been heard, and our stories need to be heard, because I feel like even in my story and my situation, what if one day my kids are without their mother?
Yo puedo seguir trabajando, pero estar segura que estoy siendo tratada médicamente también.
Yeah, I can continue to work, but I also want to make sure that I'm being cared for medically.
Siento que es mi derecho. Muchas gracias.
I do feel that this is my right. Thank you so much.
Go ahead and proceed when you're ready.
Hola, buenas tardes. Mi nombre es Elizabeth López.
Hello. Good afternoon. My name is, dijo Elizabeth Lopez?
Yes, sí.
Sí, my name is Elizabeth Lopez.
Soy miembro de Make the World Nevada. Vengo de Las Vegas para hablar de un tema que no es solo importante para mí, sino también para mi comunidad.
And I'm a member of Make the Road Nevada, and I'm here to talk about a topic that's not just important for myself, but also for the community.
Vivir sin seguro médico ha sido un gran desafío en mi vida.
Living without medical insurance has been a big challenge in my life.
La incapacidad de acceder a la atención médica cuando se necesita ha llevado a una falta de confianza y apoyo en el sistema de salud.
And being without medical insurance in the moments when you need it most has caused for one to not have confidence or faith in the health system.
Porque cuando tengo que hacer una cita en el doctor, tengo que pagar de $400 a $500 por mi tratamiento de diabetes.
Because when I have to make a medical appointment, I have to pay around $400 to $500 for my diabetes treatment.
Y cuando mi sueldo no pasa de 500.
And this is when my income doesn't come out to more than 500.
Hay momentos que no puedo y pienso que pagaré la consulta, los exámenes, los resultados, todo tengo que pagar por separado y para mí es muy difícil.
And sometimes there are moments when I ask myself, do I pay for the consult, for the test, for the results? I have to decide on which one, and that's something that's very difficult for me.
Hay momentos que pasa el tiempo y la verdad pasa el tiempo y no puedo hacer mis resultados porque es costoso para mí.
And there are moments when time goes by and just time and time goes by and I'm not able to get my results because really it's a lot financially for me.
Ya lo único que hago, por último, solo voy y cambio mi medicina.
The only thing I end up doing at the end is just going to get my medication.
Es tan difícil pasar por esto.
It's so difficult to go through this.
Porque la verdad, esto no es un lujo, sino una necesidad.
Because in reality, this is not a luxury, it's a need.
Es muy costoso ir al doctor.
It's very expensive to go to the doctor.
Y desesperante. Cuando tu hijo te
And it's
dice,
anxiousness.
mamá, me duele aquí, mamá, me duele allá. Es ok, mami, toma una Tylenol, vas a estar bien.
When my child tells me, Mom, it hurts here, Mom, it hurt there, and I just have to say, it's okay, take a Tylenol, you're going to be fine.
Por dentro te consume ese dolor, esa desesperación por no tener ese dinero en la mano y poder tener esa aseguranza y ir con esa confianza y decir, llevo a mi hijo sin ningún problema.
That pain, that desperation overwhelms one because one doesn't have that assurance to be able to just go to the doctor.
Créame, es muy difícil. Y esto no
Believe
es
me, it's very difficult.
un lujo, sino una necesidad. Gracias.
And this is not a luxury, this is a need. Thank you.
Good afternoon, Chairwoman and members of the committee. My name is Victoria Ruiz, that is Victoria, last name Ruiz, and I am a constituent of Clark County. I'm here to thank Senator Doñate for sponsoring SB 419 and to ask you to ensure that it moves forward. As an immigrant woman who has called Nevada home since I arrived in the U.S. at the age of 8, I have felt firsthand the effects of not being able to access health care that I needed and have had to support others in my community during similar moments. I think you've heard several stories today illustrating the need for this health care. No one should go without the necessary preventative care or medical treatment that they need over something like status, especially in a state where immigrants have been part of the state's fabric for decades and played a critical role in our economic recovery after the COVID-19 pandemic or outbreak. There simply would be no recovery without immigrants. The reality is that a person's immigration status has absolutely no relevance to a medical professional's ability to provide care. In addition, the social and health disparities amongst immigrants in this country and state are by design, as is the case for several other issues that disproportionately affect us. At this moment, you have the power to do something about it and make good on your values of making healthcare accessible. Immigrants across our state who are just as much Nevada as the next person, and who also pay taxes since 1996 when the IRS figured out how to do that through individual taxpayer numbers, are looking to you to deliver on this bill and recognize that our lives and wellness are worth taking definitive action. I think I also want to mention that for many constituents, no matter the side of the issue that we stand, we want to see our elected officials spending precious time discussing real solutions and not on strategic call-outs that should be happening behind closed doors. So thank you for allowing me to testify today. I hope that the conversations remain productive and not strategic. Thank you.
And I'm looking in Las Vegas. I don't see anyone in that room. So do we have any other testimony in support? I will go again to testimony. Oh, broadcast services. Is there anyone on the line to testify in support?
If you are in need of a Spanish to English translation and would like to testify in support of SB 419, please press *9 to join the queue.
Si usted necesita los servicios de interpretación del español al inglés para poder dar su apoyo a SB 419, favor de oprimir estrella 9 para poder colocarlo en línea para comentar.
If you would like to testify in support of SB 419 and do not require translation, please press *9 to take your place in the queue. Chair, there are no callers choosing to testify in support at this time.
And I will turn again to opposition testimony. If there's anyone to testify in opposition, both in Las Vegas or Carson City, please come up to the table. Seeing no one coming up to the table, broadcast services, can we go to the line to see if there's anyone to testify in opposition?
If you would like to testify in opposition of SB 419 and are in need of a Spanish to English translation, please press *9 now to join the queue.
Si usted le gustaría dar su testimonio en oposición al SB 419 y necesita interpretación del español al inglés, favor de oprimir estrella 9 para poder colocarlo en línea para comentar.
If you would like to testify in opposition to SB 419 and do not require translation, please press *9 to take your place in the queue.
Hi, my name is Lisa Partee, P as in Paul, A-R, T as in Tom, E-E. I am the one who mentioned the signs and the stickers on the earlier call. They were down in Las Vegas. There was a girl in the audience with a sign. There is a girl in the Carson City location that was passing out stickers. Obviously down in Vegas too, as I saw stickers down there. That's what my point was. There were stickers in both locations. And the sign was down in Las Vegas.
Thank you for that,
Thank
and
you.
we will lodge your testimony in opposition from before.
Thank you.
Broadcast services, is there anyone else on the line in opposition?
Good evening, committee. I'm Jim DeGraffenreed, National Committee Man for Nevada, in opposition to SB 419 on behalf of the Nevada Republican Party. Our platform specifically opposes government benefits or other special treatment for those who enter our country illegally. Proponents spoke today about how similar legislation has reduced uninsured rates. As a health insurance professional, I know these statistics are often meaningless. Being insured with a plan you can't afford to use due to high deductibles is effectively the same as having no insurance. The Affordable Care Act roughly quadrupled health insurance premiums, increasing insurance company profits while passing most of the cost on to taxpayers. Support for SB 219 from the hospital industry is reminiscent of those debates, as SB 219 provides a huge financial benefit to medical corporations at taxpayer expense. The discussion of how the pandemic exposed problems with healthcare delivery and payment is also disingenuous. Photos of an empty Las Vegas Strip don't have anything to do with healthcare delivery. Medicaid, which is the solution proposed in SB 419, was massively expanded during the pandemic, and in fact this increase has persisted well past the end of the so-called public health emergency and won't even begin to be addressed until April 1st of this year. The proposal to transfer the cost of care for non-citizens from hospitals to taxpayers via Medicaid has unintended consequences. Nevada encourages illegal immigration when we offer welfare benefits that other states do not. Nevada already has among the highest proportion of illegal immigrants of any U.S. state, even without this incentive, so it seems reasonable that the cost will be much higher than the estimated $78 million, potentially billions of dollars. In Section 39, SB 419 incredibly suggests that there may be federal funds available to help Nevada pay for this insanity. While 8 U.S. Code Section 1621 does allow states to pass laws giving non-citizens benefits, the majority of that federal law is devoted to stating that aliens are not eligible for government aid, so the chances of the federal government supporting this scheme to encourage more illegal immigration into Nevada are slim to none. This bill is a major financial giveaway benefiting corporations at the expense of taxpayers. We should not discuss a single penny of taxpayer money going to aliens until every last homeless veteran is sheltered, every American citizen in foster care has found their forever home with a loving family, and every Nevadan lives in a neighborhood free of crime. We urge this committee to work for Nevadans and oppose SB 419. Thank you.
We can go to the next caller in opposition.
Good evening, Madam Chair and esteemed members of this committee. My name is Charlotte Stewart, and I'm a resident, a parent, and a board member of Health Freedom Nevada. We are a nonpartisan, grassroots, all-volunteer organization representing approximately 5,000 Nevada families, and we serve as the Nevada affiliate of both Children's Health Defense and Stand for Health Freedom, national organizations whose missions align with our own. Our founding principles include the right of every citizen and every parent or guardian in the case of a minor child to true and full informed consent to any and all medical and pharmaceutical interventions, religious freedom, and parental rights in all personal healthcare decisions. Health Freedom Nevada strongly opposes SB 419. We are strongly opposed to the expansion of public health measures that have failed us miserably in the last couple of years. Please vote no on SB 419. Thank you.
What? Can we go to the next caller?
Yes, ma'am. This is John Carlo, the young gentleman from Las Vegas. I've been in this meeting for over 3 hours just to testify and to say I am a Hispanic. My dad is from Mexico. I speak Spanish and another Asian language. I'm a union member also, and I want to thank the senators, Mr. Stone and Mrs. Titus, and really Mr. Stone for being the voice of reason and on this committee. Healthcare is not a basic human right. It's in the Bible. The godly and the ungodly suffer alike. AB 419 goes against union jobs. And basically, I have been struggling finding a job because there's so many illegal immigrants taking construction jobs. And then I like for you guys to recognize Cesar Chavez. And I think you guys are renaming Northern Pecos Cesar Chavez, who originally fought against illegal immigration, and he unionized farmers. And so I'm against AB 416 for the fact of it is enticing the criminal act of illegal immigration to this country. I quote from the Cornell Law School, the 8th U.S. Code 1324A, as it speaks to the unlawful employment of aliens. And basically, I mean, this is like 2 plus 2. Basically, is we're saying come to Las Vegas. We will take care of your medical needs. I say lower the cost of education and stop voting for federal senators who are funding wars on the other side of the world. We are facing an unbalanced amount of power.
If I can go ahead and have you wrap up your testimony, you're just at 2 minutes.
Yes, so yes, ma'am, we have a major border problem, and basically hiring and referring illegal aliens goes against NRS 232.521 and 360.796. Thank you guys very much.
Do we have any other callers in opposition?
Thank you, Chair. If you have just joined us and are requiring Spanish to English translation and would like to testify in opposition to SB 419, please press star 9 to take your place in the queue.
Hola, si se acaba de reunir con nosotros, si le gustaría dar su testimonio en oposición a SB 419 y necesita los servicios de interpretación del español al inglés, favor de oprimir estrella 9 para poder colocarse en línea para dar su comentario.
Hello?
Hi, are you here to testify in
Can you hear me?
opposition?
Yes, I oppose this health care for illegals.
Can you please state your name for the record, please?
Elena Deniger, Deniger. Hear me?
I can hear you. Go ahead and proceed with your testimony.
Yes, I oppose health care for illegals. There are too many people on the streets. I talk to them every day. None of these people have health care insurance. I don't want any taxpayers to have to pay for health care for illegals. And you go into the doctor's office, the emergency rooms, these places are flooded with them. Sometimes you can't get care for 12 or more hours because of the fact that these emergency rooms are flooded with them. This isn't fair. I've been a United States citizen all my life, well over 55 years, and I have never seen anything like what's going on right now. I oppose this.
Thank you. And do we have any
Chair,
other callers?
there are no additional.
I spoke
My
too soon.
apologies, Chair.
Go ahead.
There are no additional callers for testimony at this time.
Thank you. And I'm looking here finally in neutral. I don't see anyone coming to the table in Las Vegas or in Carson City, and it doesn't appear that there is anyone on the lines to testify in neutral. So at this time, I will ask the bill sponsor to come back to the table. Oh, no, he's waiving any closing statements. So at this time, I will close testimony on and close the hearing on Senate Bill 419 and turn the gavel back over to our chair to begin our last agenda item.
Thank you so much. The last agenda item for today is public comment. Is there anyone that would like to provide public comment at this time? We don't have anyone in Carson City, anyone in Las Vegas, and BPS, anyone virtually.
If you are in need of a Spanish to English translation and would like to provide public comment, please press star 9 now to join the queue.
Si usted necesita interpretación del español al inglés y le gustaría dar un comentario público, favor de oprimir estrella 9 en este momento.
If you do not require translation and would like to provide public comment, please press star 9 to take your place in the queue.
My name is Cyrus, Cyrus. From what I heard, it seems like there's a lot of unauthorized immigrants that are working on the strip, directly or indirectly. And there's a lot of relatives out here that there's a lot of elected officials that have relatives who have not come here the proper way. I'm hearing a lot of people express pain and frustration over the COVID period during the lockdowns and everything. Well, now I see the true colors. You guys try to portray yourself as victims. You have job losses, financial turmoil, inflation. Well, here's the sad truth. A lot of these paid activist organizations and I can go on and on. There's so many out there. They're the ones who supported the lockdowns, the mask mandates, the vaccines. A lot of people got harassed. The fact that there were a lot of politicians, they continued to promote this stuff. And have we gotten a report that whether these efforts actually worked? You know, if this is just based on lies, deception, and everything else, in fact, you guys use social justice. This system made a lot of wealthy white males incredibly rich. A lot of casino executives profited. We can see this is all part of the whole political machine of casinos, unions, this political dynasty. And congratulations, you've exposed it. We see the global agenda. It's to destroy our traditional values, destroy the middle class, promote foot soldiers. This is what we see from open borders. And when are we going to get some accountability for all this? We know Fauci's in trouble right now. Think about it. And you see, in casino taxes don't go up. Middle class people have to pay for this. Financial system isn't crumbling. Nevada used to be the fastest growing state, the lowest unemployment, and now it's no longer in the top 10 fastest growing. The unemployment is among the highest. This is clearly going in the wrong direction. So thank you for exposing the true agenda of all this, and we will have some accountability. Yield my time.
Thank you so much. Anyone else in public comment, BPS?
Yes, I'm here. This is John Carlo, and basically, I do ditto Cyrus. He has a lot of good things to say, and there are the lockdowns destroyed us, but basically, there's just not jobs here. I mean, I know there's going to be hearings tomorrow, and I mean, where the jobs are coming here, and then it came out in the meeting today that we don't know how many illegals exist in this state. And that's another problem. I mean, you guys are supposed to be the leaders of this state and making good policies. And I'm depending on you guys to audit CCSD for public safety and all these things. I'm really depending on you guys to make the best decisions. And these decisions are going to have detrimental effects on this state. And we're volunteers here. We are speaking from our heart. We're speaking from our experience and what's going on in the state. Like I told you guys, I have been struggling finding a job. Now, and I will tell you, in my industry, there are many illegal immigrants. And this is what Cesar Chavez fought for. Cesar Chavez fought against illegal immigration. And I can't believe that his name is being used and abused by the Democrats. I hope you guys have a good night. Thank you.
Thank you so much, BPS. Anyone else in public comment?
Chair, there are no additional callers choosing to provide comment at this time.
Thank you so much. That concludes our meeting for today. Meeting's adjourned.